So today we are going to talk about antibiotics, right? Especially antibacterial drugs, right? And when we talk about antibacterial drugs, you know there are many different types of antibacterial drugs which work in different ways on the bacteria. The first group of drugs which we will discuss is those antibiotics which inhibit the synthesis of bacterial cell wall, right? Which antibiotics we are going to discuss? The group of antibiotics which inhibit the synthesis of cell wall. Such antibiotics are also called cell wall active agents. Cell wall active agents, right? You must be knowing there are some very important drugs which are in this group. Can you tell me the names of the drugs which are bacterial cell wall synthesis inhibitors? Cycloserine, bactericidal, vancomycin, yes, and beta-lactam group of antibiotics, beta-lactam group of antibiotics. And in the beta-lactam group of antibiotics, what antibiotics are present over there? Yes, there are four very important members, at least four of them you should know. Yes, penicillins, yes, cephalosporins, yes, please, penicillins, cephalosporins, imipenem group, which is basically group of carbapenem, and yes, carbapenem and aztreonam. Now, out of all this group, the very commonly used is the penicillin group, isn't it? And cephalosporin group, and of course in certain situations other drugs are also used, right? So all of these drugs groups, cycloserine, bactericidal, vancomycin, beta-lactam antibiotics, such antibiotics which have beta-lactam ring, they are penicillins, cephalosporins, carbapenem and aztreonam, right? We are going, basically our initial discussion is about this group of antibiotics, fine. Before we really go into detail of these antibiotics, I am interested that we should know what is the normal structure of bacterial cell wall and how the bacterial cell wall is synthesized. Then we will really understand how these antibiotics disrupt the synthesis of bacterial cell wall. Now, basically most of the bacteria are divided into two groups, gram positive and gram negative, right? Most of bacteria, there are some exceptions also, we will not talk about them now. So there are gram positive bacteria and there are gram negative bacteria. Let us suppose as an example of gram positive bacteria I put a staphylococcus here, right? Gram positive bacteria, and as gram negative bacteria I can put here, yes, pseudomonal, okay, or you can put E. coli, that is very friendly, you have a lot of it. E. coli is here. And now this is the cytoplasmic membrane of staphylococcus, this is the cytoplasmic membrane of E. coli. In this diagram I have not made the cell wall of gram positive bacteria or cell wall of gram negative bacteria, right? Now, how the cell wall of gram positive bacteria is different from gram negative. Remember, gram positive cell wall has a big difference from gram negative bacteria cell wall, and due to this differences in the cell wall, the drugs work on the gram positive are maybe different and drugs working on the gram negative may be different, right? So what is the difference in the structure of cell wall of gram positive bacteria and gram negative bacteria? Raise your hands please. thickness of the, so our friend is telling that the differences in thickness, which one is thicker? Gram positive is thicker, and you think gram negative cell wall is thinner. So due to this reason, yes, due to this reason, antibiotics, penicillins, suppose penicillin G should be more effective on gram positive or more effective on gram negative. So, but you say gram positive, you understand how I'm trying to put a very basic concept in your mind. I asked you what is the difference. You said this is a thicker cell wall and this is thinner cell wall. I bring a question that penicillin G, it is more effective on gram positive or negative. Of course, all of you know it is more on gram positive and less on gram negative. Why this difference is there? Yes, please. If you can answer this, then you really know the difference of the cell wall, otherwise not. Yes. Anyone? Okay, before you tell me the very new things, let me tell you what is the basic structure of cell wall of the gram positive, and then I will tell you how it is different from gram negative. In gram positive bacteria, what really happens, cell wall consists of two components primarily. Number one, there are sugar backbones. What are there? There are sugar backbones, and those sugar backbones I am going to make blue. These are sugar backbones. I will show the detailed structure of it in a short time. These are the sugar backbones. Now these sugar backbones which are there, of course they are made of carbohydrates. These sugar backbones are cross-linked. You know, they are cross-linked through peptide chains. What is there? Peptide chains. Sugar is also called glycan. What is it called? Glycan. So this whole molecule which is making this cell wall, this is called peptidoglycan. What is it called? Peptidoglycan. So cell wall of gram positive bacteria is mainly made of sugar backbones cross-linked with, yes, cross-linked with peptide chains. Cross-linked with peptide chains. And due to this reason, they are called that gram positive bacteria have cell wall made of peptidoglycans. Is that right? How many molecules of peptidoglycan make one cell wall? Anyone who knows the answer? It's a funny question, but still it will tell me how clear your concepts are. How many molecules of peptidoglycan make one cell wall? Zishan is telling it's one, and answer is right. It is just one molecule. It's a many peptidoglycan polymerized into one macropolymer. Okay? Peptidoglycan, just this is one macropolymer of what? Peptidoglycan. And this is making gram positive cell wall. But when you go to the gram negative cell wall, there is also peptidoglycan. And as you will feel for a while that your friend was very right, there is also, what are these? Glycan backbones. And what are these? Yes, please. Peptide cross-links. Right? So again, this is also peptidoglycan. So you see, gram positive has peptidoglycan as well as gram negative have a cell wall of peptidoglycan. And as your friend was telling, it is very thick and that is looking very thin. But the clinically important thing is something else. Gram negative bacteria have an additional outer membrane which is not present in gram positive. Look at this beautiful membrane. This is an additional membrane, lipid membrane, which is present on gram negative and which is not present in gram positive. We call it outer membrane. So outer membrane is an additional and very special and unique feature of gram negative bacteria, but not a feature of gram positive. This is the most important difference in gram-positive and negative bacteria. The cell wall difference. The reason being, this is clinically very important difference. Number one. Let me tell you how the penicillins work. Actually, penicillin binding proteins are present here. They are attached with, what is this? What is this? Cytoplasmic membrane. What is this? Cytoplasmic membrane. And penicillin binding proteins are present on where? Cytoplasmic membrane. It means if penicillins or beta-lactam antibiotic have to attack these proteins, is that right? If penicillins have to attack these proteins, then as I told you, the beta-lactam antibiotics have a special 4-member ring which is called, what is this ring? Beta-lactam ring. Suppose this is the structure of penicillin, and this special ring is called, what is this ring? Beta-lactam ring. And this is the ring which basically interact with penicillin binding proteins, target proteins. Now, you must know where exactly the penicillin binding proteins are present in bacteria. Penicillin binding proteins are present in bacteria on the outer side of the cytoplasmic membrane. It means that penicillin has to go all the way, yes, up to here, and then penicillin will bind with the proteins. You are getting it? Claro? Now, this peptidoglycan network is highly porous. It is just like a network. It is highly porous. So even larger antibiotics can go up to that and attack the proteins. Am I right? But here, in case of gram-negative bacteria, still penicillin binding proteins are present on inner cytoplasmic membrane. It means penicillin or beta-lactam antibiotics need to go up to this place. But the trouble is there waiting for you, that this is the beta-lactam antibiotic, it want to go, but outer membrane is there. Outer membrane is what? It is made of lipids, and because it is made of lipid, it is not highly porous. Is that right? Due to this reason, many antibiotics which are larger, bulky, their molecular structure is very bulky, or their molecular structure is very highly charged. Can they pass through this membrane? No. So they cannot act on gram-negative bacteria. Even though gram-negative bacteria have special mechanisms to transport certain substances through its outer membrane. And these special things which are present in the outer membrane, these are called porins. What are these? Porins. These are special. This is lipid membrane with protein pores. And what are these pores called, please? Porins. What are these pores called? Porins. Right? So actually gram-negative bacteria have an outer membrane, and in the outer membrane they have porins. Is that right? And any cell wall active agent which has to go to the target proteins, it has to pass through the porins. And if some antibiotic cannot pass through the porin, can they really act on the gram-negative bacteria? No. Now I think you got your answer, that penicillin G is very bulky molecule. Because it is bulky molecule, penicillin G, right, can go through this porous peptidoglycan of the gram-positive and can reach up to the target. But penicillin G cannot effectively pass through the porins, so it is not very effective because it cannot reach up to the target protein. I hope you have your answer. Then another group of penicillins are very narrow spectrum penicillin. Let's continue discussion. That I put penicillins here. Penicillins, and penicillins are basically two types, narrow spectrum and wide spectrum. It's so easy to think in these terms, narrow spectrum and wide spectrum. It is killing less organisms, this is killing many different type of organisms. But the question is that why narrow spectrum is narrow and why wide spectrum is wide? In narrow spectrum, there are two. There are natural, right, penicillins, and they are very, 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 very narrow spectrum. Narrow spectrum. It means natural penicillins are moderate spectrum. Out of narrow, these are less narrow and these are very, very narrow spectrum. You are understanding? Now, classically in narrow spectrum, we put the drug like, yes please, penicillin G and penicillin V. Is that right? Penicillin G and penicillin V, these are natural penicillins because they were originally derived from the special mold. Is that right? You know Fleming? Okay. Alexander, but not the Alexander the Great. Okay, so Alexander Fleming's. So actually penicillin G was discovered and found during the Second World War, and then it was utilized. It is still being used. This is still one of the very commonly used drug and very safe still. Now, penicillin G and penicillin V, they are having moderately large structure. Why? Because I have made, this is a penicillin structure. On the side of the penicillin, it is just like a beautiful house, This penicillin is a beautiful house, and there is a side room here. In this side room, you have the jail in which you capture the penicillin binding proteins. And there is a special here antenna. This is called R group. So basically penicillin structure is one big ring with one small ring. The small ring is beta-lactam ring, and on the side you can attach a special R group. Are you understanding me? This is a basic structure. Most important structure out of this is this ring, because this is the ring which is going to attack the penicillin binding protein. If this ring is destroyed, this molecule will fail. You are understanding it? That is why those enzymes which destroy this ring, they are called beta-lactamases, because they break down the beta-lactam ring. Is that right? And this is required, this integrity of this ring is required for the antibiotic action of the beta-lactam antibiotics. Am I clear? No problem up to this? Now, in case of natural penicillin, the molecule is moderately bulking. Because it is moderately bulky, right, it can easily go, natural penicillins, it can easily go to, yes, where? Gram positive. But usually in gram negative, they are not very successful, because they are larger molecules. In many gram negative bacteria, natural penicillins cannot enter through porins. That is why you know that natural penicillins like penicillin G and penicillin V, they are more effective in gram positive cocci, they are more effective in gram positive bacilli, they are more effective in gram positive cocci as well as on gram positive bacilli. Yes, they act on the gram positive bacilli. They act on few gram negative cocci, because some gram negative cocci have a slightly larger porin. They are slightly larger porin, but most of the gram negative bacilli have very narrow porins. So penicillin G or V fail on the gram negative bacilli. And of course you know that penicillin G also work on, yes, most of the gram positive, also some gram negative cocci, but not gram negative bacilli, right? And one very big group of organisms, important, not very big, but important. Again, I am trying to put something in your mind. What I am trying to tell you, the natural penicillins are moderately bulky. They are not very smart, but they are not very obese. And they can go through most of the, they can reach up to the most of penicillin binding proteins of the gram positive, bacilli and cocci both. In gram negative, they can go through the porins of gram negative cocci, but not gram negative bacilli. Is that right? Plus, these antibiotics can also go to, please tell me, there is one organism which produces a nasty disease. If you get it, you don't like to tell others you got it. And he knows it, he doesn't like to tell to anyone. Syphilis, yes. Right? Treponema pallidum, spirochetes or spirosheets, whatever you call it. So natural penicillins can work mainly on gram-positive cocci. They work on gram-positive bacilli. They work on gram-negative cocci. They fail on, these drugs fail on gram-negative bacilli. They cannot work on them. And they also work on these. Yeah, what are these? Spirosheets or spirochetes. Right? You know spirochetes are like Treponema pallidum. Is that right? Do you have Treponema pallidum right now, man? You don't have it. Dr. Wahid, do you have Treponema pallidum? Yeah. Yeah, in your body, not in your friend's body. You don't have it. Anyone here who has Treponema pallidum? My friend, all of you have it. Let me, where? Just open your mouth and you will know it. Actually, Treponema pallidum is present in between the, normally it is present in between the gums and the teeth. The beauty is that this Treponema pallidum is not pathogenic. Thank God. Thank God. You feel relieved, isn't it? Right? You feel relieved because the pathogenic Treponema pallidum, which really produces syphilis, right, that is sexually transmitted, all of you must be knowing, right? So anyway, let's come back. That is part of the normal flora, my friend. Yeah, treponem is a Treponema pallidum, leptospira. Yeah, icterohemorrhagica, right? This is second type of spirochete which is responsible for which disease? Weil's disease. Weil's disease, which come from the rats. Oh my God, right? And any other spirochete you know? There is another spirochete which comes from the ticks. Another spirochete disease which comes from the ticks, the disease is called Lyme disease. What is the organism? Borrelia burgdorferi, right? But we will keep our discussion limited to that penicillin G is effective, especially in syphilis. Actually, one shot of penicillin will cure the syphilis, right? Okay. But when we come to very, very narrow spectrum, look, very, very narrow spectrum are only, yes, this was natural penicillin group. Now we are going to talk about very, very narrow spectrum. What? Penicillins, right? They are so bulky molecules that they only go into Staphylococcus. But they even fail on many other gram-positive and negative. So that is why very, very narrow spectrum penicillins are simply called, yes, they are called anti-staphylococcal, yes, penicillins. Have you heard of it? Because even though other penicillins can also attack the staphylococci, but this is a special group which specifically attack the staphylococcus. Is that right? This is a very heavy molecule. Now question is that why doctors made this a very special group, that there is a full group of penicillins which are anti-staphylococcal. There are two reasons for that. One reason is that you should remember they are working on staphylococcus and they are not effective in other bacteria so well. Because these antibiotics, this penicillin has a very, very heavy R group, very, very large R group. And it is such a large R group, it cannot enter into meshwork of most of the positive or even none of the negative. That is why, but it mainly attacks the staphylococci. So it is called anti-staphylococcal what? Penicillins. Can you tell me a few names of that? Yes. Please tell me methicillin. Methicillin, which is not being used now clinically. Nefcillin. Cloxacillin. Dicloxacillin. Cloxacillin and Flucloxacillin, have you heard of them? Flucloxacillin. So all of them are specially called what? Anti-staphylococcal penicillins, right? So anti-staphylococcal penicillins, when we talk about, we specifically and specially talk about methicillin, nefcillin, cloxacillin and dicloxacillin or decloxacillin, right? Now, these are called specially anti-staphylococcal. One reason I told you, because they are so bulky, there are many bacteria cell wall they cannot pass through, because target proteins are present on the which place? Cytoplasmic membrane. And because penicillin binding proteins are present on the cytoplasmic membrane, penicillin have to go through the cell walls, right? So number one, this thing. But there is another reason why they are called anti-staphylococcal. Are you interested to know that or not? These drugs have a very special advantage over many other drugs to kill the staphylococcal. Staphylococci have become very dangerous bacteria. You know what they have done? They started making penicillin cutters. Many staphylococci are producing enzymes, and those enzymes can destroy this basement of this small jail. Let me tell you, if this is a penicillin molecule, what is this ring? This ring is beta-lactam, right? And what really happens that this staphylococcus, or many not all but many staphylococci, produce special type of very dangerous molecule. They secrete them, and these dangerous molecules which are secreted by penicillins, these dangerous molecules are very bad. You know why? They can, you know what they are doing? They are cutting the beta-lactam ring, especially at the basement. Many staphylococci produce the enzymes, and these enzymes can go and break down the beta-lactam ring. So when your penicillin is approaching there, you are throwing the penicillin on bacteria, and bacteria is throwing those dangerous what? Enzymes. And those enzymes will leak through this porous peptidoglycan and go out and destroy the penicillin even before the penicillin reaches there. Are you understanding? These molecules are called penicillinases because they break down the penicillin. They are called penicillinases. So many of the, or because they break the beta-lactam ring, they can also be called beta-lactamases. So many staphylococci are producing beta-lactamases or penicillinases. These beta-lactamases break down the beta-lactam ring. And because they break down the beta-lactam ring, so penicillin G or V cannot be effective. Are you understanding? So we needed some very special type of penicillin which can work against these bacteria. So what did we do? Very simple thing. You change this R group. You change this R group. You remember there was the R group here? You put a different type of molecule here, and that molecule should be wrapped around like this. What it is doing? It is protecting the beta-lactam ring. This side chain is protecting the beta-lactam ring. And now staphylococci which produce the beta-lactamases, can their beta-lactamase destroy beta-lactam ring? No. So doctors produce a full new class of penicillins which are modified penicillins, and they put their R groups in such a way that R group, I don't need to go into detail what they are, but there are such additional groups on the side which protect the beta-lactam ring from the beta-lactamases. So in this way, all those staphylococci which are producing beta-lactamases, these modified antibiotics could kill those bacteria because they were resistant to penicillinases. Am I clear? Now, the thing was that in this process you made the molecule smart or bulky? Bulky. So you lost the action on many other bacteria. So molecule convert into narrow spectrum, but specially effective for staphylococci. So they are called very, very narrow spectrum anti-staphylococcal penicillins. That is what all these are: methicillin, nefcillin, cloxacillin, dicloxacillin, flucloxacillin, oxacillin, all of them. So do you think this should be grouped with this one? No. Penicillin G and penicillin V are natural, and beta-lactam basement is not fortified. And penicillin G and penicillin V are very, very susceptible to the attack of beta-lactamases. So penicillin G and V are narrow spectrum, natural, beta penicillinase sensitive penicillins. And when you compare it with the next group, where you have add a big R group, spectrum become more narrow. It was natural penicillins are narrow spectrum, but these modified penicillins are extremely narrow spectrum. Is that right? But they have special protection side chain to protect the beta-lactam ring from penicillinase. So they were effective in those staphylococci which were producing what? Beta-lactamases. So this group of drugs were considered a very good group of drugs, and they were called what? Anti-staphylococcal penicillins. Anti-staphylococcal penicillins. And remember, because they are really narrow. So what are the spellings of narrow? Please tell me the spelling of narrow. N-A-R-R-O-W. Double R should remind you. Resistant. Against what resistance? Penicillinases. So very narrow spectrum are very resistant to the penicillinases, so they can work very effectively even against those staphylococci which produce penicillinases. That's so simple. Is that right? If you look at these important points related with it, these days methicillin in USA is not used clinically because methicillin produces very severe interstitial nephritis. It damages the kidney. So methicillin is mostly used these days. You hear about it when in the laboratory we are checking the sensitivity of staphylococci against certain drugs. And you know there is a super bug there, very dangerous bacteria called methicillin resistant Staphylococcus aureus. So you hear in regard of that. Nefcillin is used. But again remember, nefcillin, even though it is not as toxic as methicillin, but still nefcillin can produce in some cases what? Nephritis, interstitial nephritis. Nefcillin as what? Can you tell me the spelling of nefcillin? Yes. N-A Nefcillin. This N, look at this N. It is which color? I put the red color in it. It should remind there is something dangerous about what? About nefcillin. N stands for nephritis and N stands for neutropenia. These are two big problems with nefcillin. Is that right? Then there are other drugs like cloxacillin, dicloxacillin, flucloxacillin, right? Look at it. There's a funny thing here. There's O coming in this, isn't it? Why this O is coming there? To remind you, they are available in oral form. They are available in oral form. Is that right? Anyway, so what this was something about. Now, you are very clear about natural penicillin and very, very narrow spectrum penicillins, right? Okay, a few words about these. What is the real difference between penicillin G and penicillin V? I'm about to be impressed.
Different way to use.
Different way to use. What different way?
Oral and
yeah, actually penicillin G is usually given parenterally, intravenously suppose. And penicillin V can be given orally. Why? Penicillin G is very big, it cannot enter from mouth or what? Yeah. Yeah, actually, look, penicillin G was the most primitive molecule, right? Penicillin G. This is structure of penicillin G. Actually, this is the point where, which was attacking? Penicillinase. And it is the same point where acid of the stomach attack. Penicillinase and so basically penicillin G, this area is totally unprotected. It is not only attacked by the penicillinases and beta-lactamases of course, but it is also attacked by the HCl in stomach. So when you take penicillin G orally, it is beta-lactam ring is destroyed by the acid in the stomach of course, and then orally it is not so effective. Are you understanding? That is why usually we prefer to give penicillin G intravenously or parenterally. Is that right? Intravenously very commonly given. Am I right? But in penicillin V, there is again R group which protected not much from the penicillinase but does protect the point where acid attack. Let me tell you more clearly. This is the beta-lactam ring. This is the point where penicillinase attack. What is it? And this is the point where acid attack. The real difference between penicillin G and penicillin V is its R group come up to this level. It protects the molecule from acid but does not protect the molecule from penicillinase. So in this way, penicillin V is acid stable. That is why it can be taken orally. And if you remember, penicillin V can be taken orally. It is used in which conditions? You should know two conditions in which penicillin V is very commonly used. Yes, my friends, penicillin V. Okay, it is used in children. For which purpose, my friend? Very commonly, penicillin V is given for those children who are susceptible to rheumatic fever. You know, rheumatic fever is a complication in 3% of the population, not everyone, due to pharyngitis by Streptococcus, beta hemolyticus, Lancefield group A, rheumatogenic strains, not every strain. Look, if children suffer with sore throat, number one with Streptococcus, and that Streptococcus should be from which group? Beta hemolyticus, and should be belonging to Lancefield group A, of which strain? Rheumatogenic strain. If some children are suffering with, for example, in a school, listen carefully, in a school there are 100 children, unfortunately all those 100 children suffer with Streptococcus, beta hemolyticus, Lancefield group A, rheumatogenic strain, pharyngitis. How many of them will develop rheumatic fever? Very good. Who is going to tell me? How many of them will develop the rheumatic fever? You don't know? Yeah? But how much? Only 3%. Very good, Miguel. It's only 3%. Because 3% population is genetically pre-programmed, right, for the rheumatic fever if the specific organism produces sore throat. Is that right? We'll discuss into detail how it happens in video on the rheumatic fever. But let's come back. In children, we give penicillin V. Is that right? To prevent the oral infection by or pharyngeal infection by these bacteria for long term. We'll discuss in detail in rheumatic fever, right? Secondly, penicillin V is also given for oral infections in which there are mixed aerobic and anaerobic infections, dental infections. Penicillin V can also be used. But anyway, you know it, both of them are natural penicillins. Both of them are moderately heavy, right? And penicillin G is not acid stable, so it is preferably given parenterally. Penicillin V is acid stable, that is why it can be given orally. Then we went in the next group, very, very narrow spectrum, right? They are made so bulky that they can work only on staphylococci, but their side chains specially protect the beta-lactam ring from the attack of beta-lactamases. So they are specially effective in those staphylococci which are methicillin. You cannot be more wrong. Oh my God! You are saying that these drugs can be used in the bacteria staphylococci which are methicillin resistant. No, it can be used in those bacteria which are staphylococci which are producing penicillinase. Is that right? Because they are susceptible to methicillin. Is that right? Now let me tell you this thing. Actually, originally when we started using the penicillins, most of the staphylococci were sensitive to the drug and we were killing, doctors were really wild, right? And they were killing the staphylococci without any human rights with the penicillins, yes. Then staphylococci acquired the capability to release what? Penicillinases. Then these drugs failed. Then we responded to them. We responded to the bug in an intelligent way. We altered our weapon. So their cutter failed. And penicillinases try to attack, but penicillinases fail. And drugs still go and bind with, what is this? Penicillin binding protein. And such, then we were very happy that these nasty, you can say, bacteria which were producing staphylococci, which were producing penicillinases, we can kill them with a special group of antibiotic called anti-staphylococcal penicillins. Then one day there was a bad news. Bug decided to respond to our innovation. And you know what bug did? Previously they were producing penicillinases, and what we were doing? We were protecting this thing, and their weaponry attack failed. We attacked them well. Then some of those staphylococci, they really became unfair with us. You know what did they do? They played a foul game with us. The foul in this game was, they totally changed the structure of what is this funny thing? Penicillin binding protein. And then methicillin, nefcillin, cloxacillin, dicloxacillin, flucloxacillin, oxacillin, all of them were given. Could they bind there? And they failed. And then doctor really got upset. Then they say there's a super bug came into action, right? That we can give the penicillins on which penicillin cannot attack, but still we cannot kill the bug. And then we try to add to the penicillin clavulanic acid and other things, still penicillins fail because clavulanic acid destroy penicillinase. So doctors were really perplexed, as confused as any confused bug. So what has happened? What is going on? That those wonderful drugs which are specifically anti-staphylococcal, the drugs are not killing the staphylococci. And then they called this very nasty super bug is even methicillin resistant staphylococcus. That is why the name came. What was the name? Methicillin resistant staphylococcus aureus. I prefer to call it even methicillin resistant, right? Because most of the staphylococcus were sensitive to methicillin. Here what did they do? They alter the target protein. This was the foul play they did with us, right? But we are also very naughty. We came up with the vancomycin. Why vancomycin inhibit a step, disrupt the cell wall synthesis, a step before these proteins were needed. We'll talk about that later, right? How the other drug work. But what I wanted to tell, that anti-staphylococcal penicillins work on those staphylococci which produce penicillinases but do not work on those staphylococci which are methicillin resistant. So you understand why you were wrong, right? Okay. Then another thing came. Some doctors said, we want to really have penicillins which also work effectively on gram negative. What those doctors wanted? They wanted to extend the spectrum. This was the moderate spectrum. Here we narrowed the spectrum. Now they wanted to stretch the spectrum. That penicillins should be modified in such a way that they not only work effectively on gram positive, but they should work effectively on gram negative also. Now, it's very easy to understand that group of wider spectrum penicillins, right? If you want them, oh, you know the drug, yes, ampicillin and amoxicillin. Why it is more wider spectrum? Why makes a great doctor? Yes, why? Let me tell you. Listen, what was the real theme? The real idea was that we had natural penicillins. We have already made very narrow spectrum anti-staphylococcal penicillins which were very bulky, but we wanted some penicillins so that which can kill not only gram positive but can also extend their spectrum to gram negative. And as you are so good doctors, you know that gram negative have an outer membrane, and that is a permeability barrier for the many drugs. And only beta-lactam drug which is going to work on the gram negative, it has to pass through the porine, somehow cross the, what is this thing? Cross the outer membrane and reach up to the penicillin binding protein. So if you want some penicillin molecule to go through the porins, it should be very heavy, moderately heavy, or smart? Smart. So actually what did they do? They just trimmed the molecule, modified the molecule of penicillin, make it a smarter penicillin, like a model penicillin. You have seen the model girls? They are usually smart girls, isn't it? You have seen in your life? You have only seen model girls. They were model penicillins. They made the penicillin which was smarter penicillin. So smart penicillin which could sneak through the porins. And of course, if they could slip through the porins, they could of course reach up to this point also. So those penicillins which could, of course, they were smart penicillin, I must say, smart penicillin. Smart penicillins, right, they could not only attack gram positive but also could attack gram negative. Because they could attack the gram negative, we say their spectrum is extended, right, they are wider spectrum. So the typical example of such smart penicillins are, yes please, tell me, ampicillin and amoxicillin, right? Amoxicillin and ampicillin, right? These are two typical extended spectrum penicillins. These are smart penicillin. They can slip through the porins. So they have not only attack against the gram positive, but they also attack the gram negative. As you must be knowing that we should remember something, that amoxicillin and ampicillin type drugs, right, they can help in gram negative bacteria also. So you can write it here that they help. What are the spellings of help? E-L. So these amoxicillin or ampicillin helps to clear very special bug, enterococci. Now you may be thinking what happened to Dr. Najeeb, why he is writing this strange type of statement. Like ampicillin helps to clear enterococci. First of all, I would concentrate what is meant by the enterococci and then helps. Look, enterococci are enterococci are the cocci, and most of the penicillin, these penicillins fail on enterococci. You know that, right? Why these penicillins fail on enterococci? Enterococci are gram positive or negative? Enterococci are gram positive or negative? Negative, okay, thank you very much. So it means they must be having porins. And the porins are little tight. Because they are little tight, so we needed smart penicillins or heavy penicillins? Smart. So actually, amoxicillin or ampicillin type drugs can help to clear the enterococcal infection, for example, enterococcal urinary tract infections. Is that right? But why I write here help? Okay, help means that H stands for Haemophilus influenza, E is for E. coli, L is for Listeria monocytogenes. Is that right? Listeria monocytogenes is gram positive or negative? It is gram positive. It is gram positive, but of course others are gram negative. P is Proteus. P is Proteus. Never call it Pseudomonas. This P here is Proteus. When you say Pseudomonas, it means you don't know penicillins. I will tell you why I am not calling it Pseudomonas. In very few minutes of lecture you will be clear. So Haemophilus influenza, E. coli, Listeria monocytogenes, what is this? Proteus. and Salmonella helps. So ampicillin helps to clear enterococci even, right? Where your earlier drug will fail, natural penicillins may not be very effective. Very narrow spectrum penicillin, anti-staphylococcal penicillin may not be effective, right? But these smart ampicillin can help you to clear the enterococci. Is that right? Now out of this, Haemophilus influenza, E. coli, Proteus and Salmonella gram negative, and enterococci are gram negative. Listeria is the only one which is gram positive here. And here I think I should remind you, the gram negative bacteria have endotoxins and gram positive bacteria have endotoxins or not endotoxins? People who believe only gram negative bacteria have endotoxins raise their hands. Have you heard of endotoxins? Lipopolysaccharide, they are present in gram positive or negative. People who believe it is in negative only raise their hand. For practical purposes, lipopolysaccharides which are having the endotoxins, for practical purposes, they are only present in gram negative. That is why I asked you, please tell me the structure of gram negative, because lipopolysaccharides are the part of outer membrane, because only gram negative bacteria have outer membrane. That is why only gram negative bacteria have lipopolysaccharide, and only gram negative bacteria can produce endotoxemia. Am I clear? Is that right? But there is only 1 gram positive bacteria which has a little lipopolysaccharide or little endotoxin. That only exception is Listeria monocytogenes, right? All gram negative bacteria have special lipopolysaccharides in their outer membrane, which are also called endotoxins. I will go into detail. You will see this thing in detail in microbiology videos, right? What is lipopolysaccharide and endotoxins and how they work. For a while, you just trust me, I'm right. And only gram positive bacteria which has endotoxins is Listeria monocytogenes. Look at it. Here it is still grouped with gram negative helps, even though it is gram positive. Anyway, so these were smart penicillins, amoxicillin and ampicillin. They were very smart. Do you think the models are well covered or undercovered? When you are beautiful, you like to show, isn't it? And when you like to show, sometimes you end up into troubles. Do you or not? This is what really happens with this model penicillin, amoxicillin and ampicillin. They are smart. If they are very smart, their side chains should be heavy or very little. They should have a very small, beautiful side chain, so that they can slip through porins. Ampicillin and amoxicillin are smart penicillins. Their side chains should be really very small, right? And due to this reason, do you think they can protect their beta-lactam ring? Can they protect their beta-lactam ring? So what happens? They are very smart. They love to expose. And what is exposed there? Don't tell me anything nasty. What is exposed there? Base of the beta-lactam ring. And who will attack from down there? Why you are smiling all? This drug I'm talking about, right? What will attack there? Beta-lactamases. So what you have to remember now, that stretching the spectrum has a price. When you make the penicillins very smart, they again become vulnerable to beta-lactamases. That is why with these drugs, we add some other drug which can neutralize beta-lactamases. Is that right? For example, when we give amoxicillin, with amoxicillin we add another drug, and that drug is called clavulanic acid. Clavulanic acid. What clavulanic acid is doing? You know what it is doing? Let me tell you. Look. For example, this is a bacteria, and which is producing, what is this? What is this? What is this? Beta-lactamase, right? What clavulanic acid is doing. Now, beta-lactamase what is the real worry? That when we have made this penicillin very smart, right? The real worry is that if bacteria is producing beta-lactamases or penicillinases, these will attack this base of the drug and destroy the beta-lactam ring destroyer. Is that right? And this ring is not protected there. So what we do with this drug, we send another what? Another drug, and that additional drug is what is this additional drug? Clavulanic acid. Clavulanic acid will fit over here. And now, what is this thing? Beta-lactamases are busy with clavulanic acid and they cannot attack the beta-lactam ring. So these are called anti-beta-lactamase drugs. Anti-beta-lactamase drugs are clavulanic acid, sulbactam and tazobactam. There are three. What are these three? Number one is clavulanic acid, number two is sulbactam, tazobactam. So what these drugs are doing? These drugs, these are the three friends which protect, they go along with the penicillins, right? They are the bodyguards of penicillins. They protect the penicillins from, as you know, some ladies are keeping bodyguards with them. It's like that. They protect the ladies from, not ladies, drug from, you know, many models, yes, they need what? Bodyguards, models, because they're too beautiful and exposed also, and their basement, this base of the ring is not properly protected. So for models should keep what? Bodyguards. So these model antibiotics, amoxicillin and ampicillin, they should go with some bodyguards. Bodyguards are here clavulanic acid molecules which will destroy the attackers. Who are those attackers? Yeah. Other bodyguards are sulbactam and tazobactam. You understand it, right? Of course, amoxicillin is coming with the name of, amoxicillin with clavulanic acid is coming with the name of augmentin. You know augmentin? So what is augmentin? Amoxicillin, which can kill gram-positive with extended spectrum from gram-negative. With them, these are very smart, beautiful, so we send the clavulanic acid with them. Is that right? So what really happens, that augmentin is there with ampicillin. Okay, the bodyguard of amoxicillin is clavulanic acid. Who is the bodyguard of ampicillin? Sulbactam. This combo is called augmentin, and this combo is called ampicillin with sulbactam. It is coming with which name in the market? You people are practicing, I'm not. Unacin. Have you heard of Unacin? Unacin. This is augmentin. Augmentina, which you call it. Is that right? So what are these? Whenever you hold Unacin or augmentin, you are sending a very smart, beautiful penicillin, which will not only attack the gram-positive but also slip through the porins into gram-negative, and we are sending the bodyguards with them, anti-clavulanic, anti-penicillinase drug like clavulanic acid or sulbactam. Am I clear? Okay, so this is extended spectrum, but there is one problem, my friend. There is one problem still. There is an organism which produces green pus. Green pus. Actually, what was happening, doctors were very happy after having the extended spectrum penicillins along with the clavulanic acid. They say, okay, we are killing many gram-positive and many gram-negative. Wow! But there was another trouble. Sometimes surgeons will open the wound, they'll look there and there's no wow, because there's a green pus, and surgeon face will become down. Why? Because he knows it was few years back, not now. About 10-15 years back, whenever surgeon look at the green pus, he knows he is in trouble. Because green pus was produced by an organism called Pseudomonas aeruginosa, and Pseudomonas aeruginosa protect it wonderfully. Some people say Pseudomonas aeruginosa has very few porins, very little porins, and even those porins are very, very tight. Even some authorities believe that practically Pseudomonas does not have porin. Due to this reason, surgeon's face go down. When he sees a green pus, you say, my God, if it is Pseudomonas, my extended spectrum formula will fail. My model antibiotic, model penicillin cannot reach there to the goal. When model fails, who will succeed? What is your general knowledge? If model fails, who will succeed? Supermodel. Where model fails, supermodel should become successful. You must be knowing models have extended spectrum, but supermodels have very extended spectrum. Every kind of male is suffering, right? So then doctors made super smart penicillins, right? And those super smart penicillins could work on many gram-negative, including Pseudomonas. And to remember these special feature of super smart penicillins, they call those penicillin anti-pseudomonal penicillins. What they call them? Anti-pseudomonal penicillins. So they were very smart penicillins. Smart penicillins. Or you can say, look here. Let's come back. They were natural penicillins. Natural penicillins were? Yes. It was moderate structure penicillin, moderate weight penicillin. Narrow spectra are obese. These were smart, ampicillin, and these are super smart, supermodel. Model. This is housewife. And here is the grandmother. Very obese. Right? So supermodels are the penicillins which are very smart. Even they can go through very narrow porins, and even they can destroy the Pseudomonas. Right? And those were called anti-pseudomonal penicillins. Is that right? So these days when they look at the green pus, they are worried, but not that much. They know we have anti-pseudomonal drugs. Of course, supermodels are very smart. Do you think they are vulnerable to attack or not? Of course, he knows it. He keeps his eye there. Supermodels expose too much. Their R chain is very small. You are understanding? Supermodel is not like this. Even this is not there. You know it. Too beautiful. Too much exposure. So they are high risk of what? Attack by beta-lactamases. So supermodels should have bodyguard or not? Sure. That is why they are also having bodyguards. For example, first I tell you what are the supermodels, and then I will tell you their bodyguards. What are these supermodel drugs? Can you tell me? First of all, tell me the most powerful, most potent, what? Most potent anti-pseudomonal penicillin. No, not imipenem. Remember, imipenem is not penicillin. I will teach you later. Yes, piperacillin, that is right. Piperacillin. Piperacillin, that's good. And then there are others like, yes, piperacillin is there. Then there is ticarcillin. Have you heard of ticarcillin? Carcillin. And then there is azlocillin. Have you heard of it? Azlocillin, meslocillin. So piperacillin, ticarcillin, azlocillin, meslocillin, and of course you should not forget carbenicillin. Carbenicillin. In one book they have mentioned a beautiful way to remember. They say Pseudomonas are really very tricky, and we should send the James Bond to fight with the Pseudomonas. And you know, James Bond goes with his special car. They have special unusual type of gadgets. It has a special car, carbenicillin. Then it has a special pipe, which is like a pipe bomb to destroy the enemy. So piperacillin. And then it has a biological weapon. Tick. Special tick which can go to the enemy and damage. Ticarcillin. So anti-pseudomonal penicillins are like James Bond penicillins. They are having a car, they are having a tick, and they are having a pipe. Special gadgets. Carbenicillin, ticarcillin, and piperacillin. Piperacillin is like a pipe bomb. In a pipe, lot of TNT dose. So that is the most potent. Potent means it is able to destroy the bacteria even at low doses. Is that right? In my lecture, potent mean this here, right? So this is the most potent. If you forget which one is out of the most potent, just look where is the P. Piperacillin, most powerful. Is that right? Then there is ticarcillin and there is carbenicillin. Now these are our supermodel penicillins, and out of them they also need some special protection. Especially, you know, car needs special care, tick needs special care, but pipe is a simple thing, you don't care for that. So with them we send the bodyguard. With ticarcillin we give clavulanic acid. What we give? Clavulanic acid. So that if this bacteria is producing penicillinases, and if the supermodel is attacked, bodyguard is there. So what is this? Ticarcillin, tick with clavulanic acid. And when ticarcillin with clavulanic acid is given, this drug or this combo is coming in the market with which name? Yes, who will tell me the name of this combo? Timentin. Have you heard of it? Okay, you will hear sometimes in your life, right? If you pursue your career in the medicine. Timentin, right? And then other drug which is also very sensitive, ticarcillin, and sorry, you have to correct it. Piperacillin also has protection. Yes, we have to correct our concept. Ticarcillin has a protection and piperacillin has protection. And protection with piperacillin is sulbactam. Why not tazobactam? We have to put tazobactam also somewhere. So basically here it is tazobactam, right? What is it? Tazobactam. And this combination, piperacillin with tazobactam. Yes, piperacillin with tazobactam. What is this combination called? Piperacillin zocin. Zocin. Anyway, let me repeat it again. We don't need to be super intelligent to understand penicillins and their classification. It's so simple that penicillins are basically one of the group of beta-lactam antibiotics, right? And penicillins natural, penicillin G and penicillin V. Penicillin G was intravenously used and penicillin V can be used orally, and both of them are like housewife with moderate weight, and with moderate weight they can kill a lot of gram positive and few gram negative. Especially they can kill gram positive cocci, gram positive bacilli with few gram negative cocci but no gram negative bacilli. Then we made them very fat, grandmothers less effective, right? So only anti-staphylococcal, right? What were these? Very narrow spectrum where R chain become very big, so they become very heavy. So action is lost on the most of the gram negative, but with heavy chain they protect their beta-lactam ring, so they can attack even against those staphylococci which produce penicillinases. They were called anti-staphylococcal penicillins. Examples were methicillin, which is not used these days, nephicillin, which produces nephritis and neutropenia, also other problems which we will talk later, and then there were cloxacillin and oxacillin, dicloxacillin and related drugs. Then we came to, we want something smart, model antibiotics, which was smart, which could slip through porins. So gram positive and negative both, extended spectrum, moxicillin and ampicillin. But because they are too smart, too much exposed, they are vulnerable to attacks. So we send them with bodyguard like clavulanic acid and sulbactam. Is that right? Then we made super smart. For which drug, which type of bug especially? Pseudomonas. Either we think either they have very narrow porins or they have very few porins, or some people say practically they don't have porin, right? For Pseudomonas we may send supermodels. What are those? Yeah, we send the James Bond with a special piperacillin, ticarcillin and carbenicillin. Is that right? And he has special protection for the ticarcillin, clavulanic acid, and with piperacillin, tazobactam, and there are other drugs also like azlocillin and meslocillin. All of them are anti-pseudomonal penicillin. Is there any question here? Let's have a break. Today we are going in the detail of how the penicillins and cephalosporins work on bacteria. As you know already that penicillins and cephalosporins are basically disrupting the bacterial cell wall and disturbing the bacterial cell wall synthesis process, right? I will explain first of all what are the different molecular steps of normal synthesis of bacterial cell wall, and then we will discuss different type of drugs which work on and inhibit or block or disrupt the different steps of bacterial cell wall synthesis, right? Who really knows the molecular steps involved in the bacterial cell wall synthesis? Do you have any idea? They are not interested in bacteria. Human beings are more interested in opposite gender, not in bacteria. No one knows how bacteria synthesize their cell wall from the very basic. Okay, let me do this dirty work. Let's suppose this is gram-positive bacteria and here is bacterial cytoplasmic membrane, right? What is it? Bacterial cytoplasmic membrane. As you know, bacterial cytoplasmic membrane consists of phospholipids. Is that right? And okay, it is like all other membranes, this is a double layer. Am I clear? Bacterial cytoplasmic membrane is a lipid bilayer of phospholipids, right? And outside this, there are bacterial cell wall components. Now, what are the real basic components of the cell wall? Last time I told you that if I make a bacteria here, I told you that outside there are glycan rods, you remember? Backbones, what are these? Sugar backbones, yes, very good. Sugar backbone, right? Glycan, and they are cross-linked with peptides. Is that right? That is what we learned last time. Now I will go into detail of this structure. Is that right? How exactly this structure works. Let me tell you that first I will go into detail of this glycan units, carbohydrate structures. Then I will go into detail of peptide cross-links, right? Actually, these structures are primarily made of two monosaccharide. This is one monosaccharide, this is another monosaccharide. These are two sugar, right? And these two sugars make one basic unit, right? Then there is another unit. Is that right? Now, what really happens that these are the double sugar units, right? And they are linked with each other here. Look here. Here they are linked with each other. Then again there is a double sugar unit and carbohydrate unit, and it is linked with each other. Now, if you look at this structure, this part and this part, right? Now this part is basically called, yes, NAM, and this is called NAG. Now let me explain. NAM stands for what? NAM is basically N-acetyl muramic acid. What is it? This stands for N-acetyl, yes, muramic acid. And NAG stands for N-acetyl, yes, glucosamine. So you can say both of these primary structures are derived from the glucose, basic carbohydrate. Everyone knows about glucose. So in the bacteria, simple monosaccharides, simple glucose units of monosaccharides undergo certain modification and they convert into N-acetyl muramic acid and N-acetyl glucosamine. Is that right? and they are fused together. Along with that, okay, what is it? This is a peptide side chain. So there is NAM and NAG unit. With NAM and NAG unit there is, what is this? A short peptide, right? Don't call it nose. It is peptide. Is that right? Now, what really happens that all of them are having, what is this unit there? Peptides. And these peptides are attached with which unit? NAM or NAG? NAM. Is that right? NAM unit has a peptide with it. Okay. Now, actually, this unit, NAM-NAG unit, they are repeating again and again in the cell wall. All this structure which is made by the multiple NAM-NAG repetition, this is called glycan backbone. What are these called? Glycan backbones. So there are glycan backbones, and what are these here? Peptide side chains. Now look, here there are also more what is this? NAM-NAG repetitions, right? Look, this bond where these double units are attached with each other, this reaction in which this unit is bound with that unit, this is called glycosylation reaction. What is this reaction? Glycosylation reaction. This is glycosylation. Yes? Glycosylation. Right? Glycosylation, glycosylation, glycosylation. And of course, all of them are having long nose. Right? What are these? These are peptide chain, peptide, short peptide chains. Now look, all of them are having these noses, and these noses are made of, yes, peptide chains. Any problem up to now? I don't know, they are kissing with each other with noses. It's a bit unusual behavior. And then what happens? A special type of reaction occurs, and in that reactions, these noses, peptide chains are, yes, they are cross-linked. What happened? They are cross-linked. They are cross-linked. So this is the basic fundamental structure of bacterial cell wall. Bacterial cell wall have long glycan units with peptide chains which are cross-linked with each other, and due to this reason we say bacterial cell wall is made of peptidoglycan. That is why we say bacterial cell walls are made of peptidoglycan. Now, this peptidoglycan structure is present all around bacteria. It is a highly porous structure. Now, what is the function of this peptidoglycan? Peptidoglycan has many functions. One function is very easy to understand, that they give the shape to the bacteria. They give the structural integrity to the bacteria, right? For example, the different type of peptidoglycan cross-linking in gram-positive bacteria and gram-negative. There's different, for example, in gram-positive bacteria, peptidoglycan layer is 80 to 100 molecules thick. And in gram-negative bacteria, peptidoglycan layer is only 2 to 3 molecules thick. But gram-negative bacteria had an additional outer membrane. Is that right? Now, how the drugs act on this structure. But before I really go for that, I'm interested to tell what is the most important function of the bacterial cell wall. Of course, it determines gram staining also, but why bacteria love to have a cell wall? And why when our drugs destroy the cell wall, bacteria die? It means bacteria, for many bacteria, cell wall is a life and death matter. Why? Why bacteria love to have a healthy cell wall? Because there are so many drugs which destroy the bacterial cell wall and bacteria die. Yes, please.
Process and the osmotic pressure between the body and the structure of the.
Excellent. He is talking about osmotic pressure. Very good. Let me explain. Actually, when bacteria are newborn bacteria, right? Their cytoplasmic components are not much concentrated. When bacteria is newborn, the cytoplasmic or intracellular components are not much concentrated, right? But as bacteria mature, they concentrate the molecules in their cytoplasm. Due to high concentration of many different types of molecules in the bacterial cell structure become hyperosmotic, and it loves to absorb water, right? So bacteria which are present in the human body, pathogenic bacteria or even non-pathogenic bacteria, many of them are having cytoplasmic material which is hyperosmotic, well concentrated. So bacteria have a tendency to absorb water, and when they absorb water, bacterial cell membranes are very weak. They are very weak. Bacterial inner membranes are very weak. So when they absorb the water, due to osmotic reasons, bacteria keep on swelling and eventually they burst. So nature has been merciful to the bacteria. To prevent this osmotic blast of the bacteria, nature has gifted the bacteria with the capability to synthesize, secrete and maintain bacterial cell wall. So cell wall is a semi-rigid structure around it. So when water comes at it swell a little, but too much swelling and osmotic burst is not allowed in the presence of strong cell wall. Now you can understand when antibiotics like penicillins and cephalosporins and other antibiotics will disrupt the bacterial cell wall, right? And then bacteria absorb the water and they undergo osmotic burst. It's a very ruthless way to kill bacteria, right? Now, we have to see how this cell wall is synthesized within bacteria. Actually, in the bacteria, the very early steps are, in cell wall synthesis are, the first of all, they will make NAM and NAG units. Is that right? For example, here is the first of all, these two units are synthesized. Suppose this is NAM and this is NAG, N-acetyl-glucosamine and acetyl-muramic acid. They are derived from the monosaccharide. So there is monosaccharide here converted into this and monosaccharides here modified into this. Once they have been modified, the next step is that in the next step with the NAM unit should be activated. You remember that these units are undergoing polymerization. They are undergoing polymerization, and it's the basic principle in biochemistry. When we have to polymerize the things, we have to polymerize some molecule, we have to activate those molecules. These molecules can be activated by addition of UDP. UDP. What is UDP? Yes, UDP, uridine diphosphate. So what really happens that first of all, the monosaccharides which are converted into NAM and NAG, the NAM and NAG unit bind with the UDP and they become activated. They are willing to react now. Is that right? Then in the next step, we have to develop here special thing. What is that? Nose. We have to get a nose, isn't it? So what really happens in the next step, this NAM unit, we add peptides here. What we add? Peptides. Now peptide, one by one, different enzyme come and add amino acids. What they are adding here? Amino acids, right? These steps are different steps, right? This is a short peptide is made on NAM. NAM is still activated by UDP and now it is getting nosy, right? And when it is getting nose, peptide nose, it is again, this peptide short chain is not due to messenger RNA translation, no. The enzymes, one enzyme come, put one amino acid, then another amino acid, then another amino acid. In the end, they put 2 alanine. Anyway, we will not go into that detail. So NAM unit develop a nose. Is that right? After that, these units are taken to where? Cell membrane. In the cell membrane, this is polar molecule, charge molecule. This is also charge molecule. Can they go out through the lipid membrane? No, they are not lipid soluble. So nature is so beautiful and fascinating. There is a very special molecule here. This will, that very big molecule is very lipid soluble. That will wrap around these units and secretly take them out. Is that right? So that unit which can wrap around this, right, we can make it here. Okay, I will write its name. This name is bactoprenol phosphate. What is its name? Bactoprenol phosphate. Right? Now, this molecule is present within the membrane. I think I should make it with different color so that you don't get confused. Within the bacterial membrane, there are special transporters which will take the small components involved in cell wall synthesis outside. So this is called, yes, bactoprenol phosphate. Now, what really happens that when these units will reach there near the cell membrane, bactoprenol phosphate will accept these units and remove the UDP, right? So let's suppose here is bactoprenol phosphate. What it is going to do? On one side, it will bind, what is this? NAM along with the nose, peptide, linker peptide, right? I should make it a little smaller, right? This is what? NAM, and along with the, what is here? Nose, right? And remove what? UDP. UDP will go away. At the same time, once it has accepted the NAM with the peptide, it will also accept, what is this? NAG. So actually both compounds eventually come over here, and then NAG will bind over NAM. So in this way, NAM along with the peptide fuse with the NAG. Now this is the precursor molecule, the basic fundamental unit, which will be repeatedly captured by the BPP and transported out. Is that right? Now after this, it will flip. When it will flip, it will look like this. It's very happy it has flipped. Right? And now it has taken what thing out? What is here? NAM, and what is this? NAG. And maybe previously there were already one NAM and NAG, right? And this was the previous nose, and now this has taken this unit and flipped out here, and there is another nose going there, right, of the new arrival unit, right? And now this NAM-NAG with the peptide cross-link has been transported out. The first thing which we need to do is that first this new unit should be linked with the previous glycan backbone. So we should stitch it here. This is one step. You are understanding it? Am I clear? This should bind with that. Second step should be that they should stitch with each other. Now, this process in which new unit fuses with the glycan backbone, this is called which reaction? Glycosylation reaction. In this case, the peptide of one unit cross-link with the peptide of other unit, this is called transpeptidase reaction, transpeptidation. So the very important two reactions, I've explained it here. Number one is this. What is this? What is this reaction? Glycosylation. And what is the process here? Transpeptidation. Is that right? And what is this? This is murine synthesis process, because these units are called as total murine unit, right? Peptidoglycan units are called murine unit. So listen, there are three main steps. Number one step, synthesis of NAM peptide and NAG, then NAM peptide NAG unit, NAM NAG unit with peptide, then transfer them outside, and then glycosylation of new unit with the glycan backbone and transpeptidation of the peptide of new unit with the previous unit. In this way, step by step, system keep on working and cell keep on synthesizing and releasing more and more NAM-NAG peptide unit, and then they are undergoing cross-linking with each other. Is that right? Now, of course, for this glycosylation unit, there should be enzymes which are doing glycosylation. Let's suppose I put a star here. The star point is what point? Glycosylation. Right? This is, yes, what is it, please? Glycosylation. Right? For this glycosylation, there is a very special enzyme attached with the membrane, and this enzyme is, look, I will make here an enzyme in the membrane. Okay, I'll make it a full star rather. This is an enzyme. What is the function of this enzyme? To do the glycosylation reaction. Then there is another enzyme here, and right, it is doing this function. What is this function? Transpeptidation. Am I clear? No problem? Okay. Once you have understood all of this, now we go one by one. What really happens? I think there's a lot of molecular, we can send a full traffic of drugs to disrupt this system. For example, first of all, we can send the cycle. Cycle, this is a drug. Yes, this drug is coming on the cycle, right? And what it is doing, this drug is primarily disrupting the synthesis of, this point. It breaks the nose. It does not allow the nose to be synthesized. In the presence of this drug, so when you are giving this drug which comes on the cycle, right? If this is present in bacteria, it will not allow the terminal amino acids which are called D-alanine. These amino acids are not bound there. So, in the presence of this drug, they will go without noses, a very little nose. And do you think you like the people with the little nose? In the same way, when this unit come out but they have little nose, can you cross-link? No. Can you really make a mechanically strong network? No. And bacteria will undergo osmotic burst. The name of this drug is cycloserine. What is this drug? Cycloserine. Right? This is the earliest, one of the earliest interaction. Then another way, what we can do? We can disrupt here. Another drug arriving here another drug arriving here in a bus, right? And this drug, when it comes here, it hangs, okay, rather I will draw it here. This drug, a new drug coming in a bus, right? What this drug is doing, it will come here and stick with this and this area. And when the bus is sticking here, it cannot reverse back. It is just like this, it flip out and a molecular bus fit into this. Once this molecular bus fit into this, can it come back? No. So can it make more units out?
No.
Can cell wall synthesis continue? No. So can bacteria survive under these circumstances? When molecular buses are there? No. What is the name of this drug? Bactericidal. What is this drug? Bactericidal. It is very toxic. That is why it is not given systemically. It is present in your topical preparation for antibiotic purposes. You have heard of bactericidal, right? So you can send this is all I think molecular traffic. First of all, you can send the cycloserine, and don't allow the precursor unit to be formed, right? Like peptide chains are not formed. Or you can give the patient, provide the bacteria, expose the bacteria to bactericidins, which inhibit the bacteriostatic phosphate to cycle again and again. I will write the name. What is this? Bacteriostatic phosphate, right? So it cannot recycle through the membrane, flip in and out, and its function is lost, right? Then we come to the next drug. We can send a van. Cycle has been there, bus has been there, right? This was your bus, bactericidal. Is that right? The next drug is a van. And what this van is doing? Van stick over here. Drug coming in the van. Do you think this enzyme will be very happy? It is attacked from many sides by the molecular vans. Now when this enzyme is blocked and attacked by the molecular vans, this enzyme becomes dysfunctional. When this enzyme becomes dysfunctional, now whatever new unit is taken out, can it undergo glycosylation unit?
No.
And can they make a strong wall?
No.
And bacteria suffer. The name of this drug is? Please tell me vancomycin. Vancomycin. Have you heard of it? That's great. Now you understand there is a cycle at very early stage, and don't allow the to make the nose. Of course, no proper nose, no cross linking. Number two is that bactericidal does not allow fail the bacteriostatic mechanism, so that precursor molecule cannot be taken out. And even if they are taken out, you can send your drugs in the van. Vancomycin block the trans glycosylation reactions, so backbones cannot be strengthened, right? And even if all of this is done, then you bring the last drug, and last drug is very, very powerful drug. Let's look at this drug. You remember this drug? Penicillin. Let me tell you, penicillin and another cephalosporins. Actually, this component is very important. This is like a jail for this. So what really happens, penicillins come, and this is beta-lactam ring. Is that right? And beta-lactam ring bind with this specific cytoplasmic membrane related enzyme. And this enzyme function was what? Transpeptidation. Right? And when you give penicillins or cephalosporins or imipenem or aztreonam, all of these antibiotics are called beta-lactam antibiotics. What beta-lactam antibiotics are doing, that all the beta-lactam antibiotics are having beta-lactam ring, and this ring can go and bind with those enzymes which are involved with the transpeptidation, and when they bind with the transpeptidations, transpeptidases do not work, right? Transpeptidases are said to be penicillin binding proteins. There are many different types of proteins present on the bacterial cytoplasmic membrane, and with those proteins penicillins can bind. So they are called penicillin binding protein. Most important penicillin binding proteins are transpeptidases, and if transpeptidases are inhibited, then you cannot cross-link. So there are many units there, but their noses are not, the peptide side chains are not cross-linked. Can you make a strong cell wall under these circumstances? No, and bacteria is in trouble and undergo osmotic burst and problem. Am I clear? Now if I asked you, there is a drug which inhibits the formation of precursor molecule for cell wall synthesis. What is the drug? Cycloserine. And if I say there is another drug which does not allow the precursor molecules, NAM-NAG-PEP unit, it is called NAM-NAG-peptide unit or NAM-NAG-PEP unit. Is that right? PEP, PEP. So there is another drug which does not allow the NAM-NAG-PEP unit to be secreted outside by inhibiting the function of bactoprenol phosphate, which are the transporters of precursor molecule from intracellular to extracellular area. What is the name of the drug? Bactericidal. And if I say that NAM-NAG-PEP unit are out, or you can say PEP, NAM-NAG unit are out, but there is a drug which does not allow the new arriving unit to get glycosylations reactions, and new units carbohydrate backbones are not stitched with each other or attached with each other. What is the name of the drug? Vancomycin. And if I say that precursor units are synthesized properly, they are transported from intracellular area to extracellular unit properly, and they are glycosylated with the backbone properly, right? Still we have opportunity to send a new group of drugs which are called beta-lactam antibiotics. They can inhibit which enzyme? Transpeptidases, and transpeptidation is not done, and peptide chains are not cross-linked, and cell wall remain weak and osmotic burst can occur. Any question after this? No. Another point which I would love to explain here is that there are many proteins which are present over here, right? Now let me put a little bit more information in your mind. There is a protein present over here which is called autolysins. What are these called? These proteins are called autolysins. Autolysin enzymes are normally present. They are present normally in the cell wall, exposed on the membrane outside. What is their function? Actually, what they do, they break down these backbones and help the bacterial cell wall to undergo remodeling, right? Old molecules are removed and new molecules are added. You are understanding, right? So there are autolysins which are in very little activity usually to produce modification in cell wall of the bacteria. Why? Because bacteria are growing, so cell wall should expand. For this purpose there are autolysins. Are you understanding me? You are not understanding. Look, babies are small. When they grow up, do you think their dress grow up? No, we bring new dress. But bacteria are very clever biologically. When they grow up, their cell walls also grow up. How? From inner side, cell wall is eaten up, and outer side, cell wall, new layers are added. This function is helped by autolysins. But normally there is a very fine balance between the new cell wall synthesis and autolysin function. A little autolysin and whatever weakness is produced immediately strengthened by the new synthetic molecule, synthesized molecule. Am I clear? So normally activity of autolysins is very well controlled because there are autolysin inhibitors. What are these? inhibitor. And these autolysin inhibitors keep autolysin inhibited so that autolysins don't work unduly too much. Because if in any bacteria autolysins are too much functional, they will destroy the cell wall and bacteria will suffer. So they are for modifications, not elimination of cell wall. They have discovered that penicillin can bind to autolysin inhibitors also and inhibit them. When autolysin inhibitors are inhibited, autolysins will become less active or more active? More active. So actually this is another way how you kill it. Number one, you don't allow the bacteria to make a healthy cell wall. That you don't allow transpeptidation. At the top, you set the autolysins free because beta-lactam enzyme can inhibit autolysin inhibitors. So autolysins work too much and they also keep on breaking multiple areas of the cell wall. So cell wall become further weak and that leads to again swelling of the bacteria and death. Am I clear? No problem into this. If someone asked you, what is the mechanism of action of beta-lactam antibiotics? It means you can explain the same mechanism for penicillins, cephalosporins, imipenem and aztreonam, right? Now, what you will say, step number one, the very important step number one, that penicillin molecule should reach to the penicillin binding proteins in an intact fashion. This is the first thing. The penicillin molecule should reach there, because if penicillin molecule cannot reach to these transpeptidases, can penicillins work? No. And as you know, penicillin G is a very heavy molecule. It cannot enter into many gram-negative molecules, gram-negative bacteria, because gram-negative bacteria have porins, and right. So penicillins don't work. So first thing which is required, that penicillins should reach to the cytoplasmic membrane on the surface of which penicillin binding proteins are expressed. Number two, penicillins should reach here with the intact beta-lactam ring, because if bacteria is secreting beta-lactamases, you are understanding me? Yes. If bacteria is secreting beta-lactamases and beta-lactamases destroy the beta-lactam ring, do you think beta-lactam antibiotic can work? No. So second requirement is that not only penicillin should be able to reach up to the penicillin binding protein, but it is very important that penicillins should reach up to their site with intact beta-lactam ring. Is that right? Here there is something very important and I think I must explain. Okay, I am going to make 1 gram positive bacteria small and 1 gram negative bacteria, right? As you know already, gram positive bacteria will have lot of peptidoglycans, right? And you know that gram negative bacteria have very little peptidoglycan, but they are having an additional what? Outer membrane. Is that right? Now, as now you have learned that this is the place where penicillin binding proteins, including which one? Transpeptidases are present, or autolysin inhibitors or other penicillin binding proteins are present. So penicillin have to reach up to this area. Is that right? And they have to reach there intact. If bacteria are producing, if bacteria, gram positive bacteria are secreting, what is this? Beta-lactamases. Remember, when beta-lactamases break down beta-lactam of penicillin, we call beta-lactamases penicillinases. What do we call them? There are beta-lactamases. Some beta-lactamases break down the beta-lactam ring of penicillins. Such beta-lactamases are called penicillinases. Is that right? There are some other beta-lactamases which can break down the beta-lactam of cephalosporin. They are called cephalosporinases. They are called cephalosporinases. So now you understand that penicillinases and cephalosporinases are types of beta-lactamases. And then there are extended spectrum. There are extended spectrum beta-lactamases, because these are very dangerous beta-lactamases. They can break down the penicillins as well as they can break down the cephalosporins. So there are three types of beta-lactamases. There are penicillinases, there are cephalosporinases, and there are extended spectrum beta-lactamases. That is why that if sometimes what happen, a bacteria is only producing penicillinases, so cephalosporins will work well. Sometimes bacteria is producing only cephalosporinases, maybe penicillin can work well, right? But it is less commonly happen like this. Sometimes bacteria is producing extended spectrum beta-lactamases, so penicillin and cephalosporins both fail. You are understanding it? Okay. Now come back. The point which I really wanted to highlight is, what is this? What is this beta-lactamases? When beta-lactamases secrete, so gram-positive bacteria secrete beta-lactamases, beta-lactamases go out, pass through the very porous peptidoglycan layer and go into extracellular fluid, and they diffuse away. So they can intercept the arrival of penicillin even when penicillin molecule is far away from bacterium. You are understanding it? Penicillin molecule is still here, but it may be attacked by beta-lactamase. But gram-negative bacteria, they can also produce beta-lactamases, but can beta-lactamases go out of the outer membrane? No. So what happens? They keep on concentrating the beta-lactamases in between the outer and inner membrane. This area between the outer and inner membrane is called periplasmic space. This is called periplasmic space. Of course, periplasmic space is present only in gram-negative bacteria. So what really happens, when gram-negative bacteria produce beta-lactamases, they really concentrate beta-lactamases in very high concentration around in the periplasmic space. And they will not destroy the penicillin molecule when it is still far away from bacteria. Is that right? But once penicillin molecule through the porine comes in, there is a very high concentration of beta-lactamases. That is one reason that gram-negative bacteria are more strongly resistant, right? Because they concentrate beta-lactamases in their periplasmic space. Am I clear? Why you people look so thoughtful? Some of you are looking very serious. Okay, so what I was telling you about, that we have talked about how the cell wall synthesis inhibitor antibiotics work. Cycloserine inhibit the synthesis of precursor unit. Bacitracin inhibit the transport of precursor unit from intracellular area to extracellular area, and vancomycin does not allow the NAMNAG unit to bind with the already present glycan backbone, and penicillin and cephalosporin and aztreonam and imipenem does not allow the does not allow the peptide chains to cross-link with each other by inhibiting transpeptidases. Then I told you, especially penicillin and cephalosporins not only inhibit the transpeptidation step and make the new synthesis of cell wall very weak, but they also make one trouble, that they inhibit the autolysin inhibitors. So autolysins are overactivated and they start damaging the cell wall. Now here we can understand one thing, that when bacteria are actively proliferating, it means they are making more and more new cell wall. So when bacteria are actively proliferating, then if you give penicillins or cephalosporins, the newborn bacteria are trying to make new cell wall. In the presence of beta-lactam antibiotics, new cell wall cannot be made and bacteria will die. Is that right? But if bacteria are not proliferating at all, bacteria are present in your body but not multiplying, it means they are not making new cell wall. and they're happy with their old cell wall, right? Then if you give penicillin and cephalosporins or other beta-lactam, bacteria already has a cell wall which is strong and fully mature. Do you think penicillin and cephalosporins can really damage the bacteria much? No. So that is why beta-lactam antibiotics are more active on actively proliferating and actively dividing bacteria. Am I clear? It means another thing, listen again carefully, that cell wall active agents are more effective when they are working on actively dividing bacteria. And penicillins and cephalosporins, if they are given to colony of bacteria which are not proliferating, they will not be able to kill effectively bacteria. Is that right? But when bacteria are actively multiplying, they are trying to make the new cell wall, it means they are working a lot with transpeptidation, and we block this reaction, bacterial cell walls will be very weak and bacteria will die. Am I clear? No problem into this. Because penicillin and cephalosporins kill the bacteria, we call it bactericidal drugs or bacteriostatic drug. Bacteriocidal, right? What is your concept of bactericidal and bacteriostatic? If I say drug A is bactericidal and drug B is bacteriostatic, what is the real difference? Because it's clinically very important to have this concept. Bactericidal and bacteriostatic. Let's suppose drug A is bactericidal and B is bacteriostatic. Of course, every doctor understands, every good doctor knows bactericidal drugs are those antibiotics which kill the bacteria, and bacteriostatic are those drugs which inhibit the further proliferation of bacteria. This is the concept of a good doctor. But some doctors are great. They have a better concept. What is the better concept? Listen carefully. Better concept is that bacteriostatic drug, bactericidal drug can eradicate the bacteria in the presence of ineffective immune system. Listen carefully. When you give penicillins or you give different drugs, you try to disturb the bacteria. Number one, drug may damage the bacteria. Number two, your immune system is also working to eliminate the bacteria. Complete eradication actually requires both things, that antibiotic damage the bacteria and immune system like neutrophils, macrophages, or with the help of complement they can eliminate bacteria. Is that right? Now, it means there are drugs coming and there are host defenses. Now, the difference is bacteriostatic drugs actually just stop the proliferation of bacteria. But elimination of bacteria is done by your own immune system, patient's own immune system. So, it means bacteriostatic drugs can be effective in patients who are immunocompetent. Now, you imagine a person who is immunosuppressed due to any reason. If person is immuno-incompetent or your patient is immunosuppressed and you do a mistake of giving him bacteriostatic drug, what will happen? Bacteria will not proliferate. But very important, but immune system is not functional enough to remove the non-proliferating bacteria. The day you will stop the drug, bacteria will again start their action. This is the problem with bacteriostatic antibiotics. Bacteriostatic antibodies require intact host defenses to eradicate microbes. The real concept about bactericidal is that bactericidal drugs can eliminate or eradicate susceptible microbes even in the absence of effective host defenses. Am I clear? So, of course, now you can understand when you end up with the patients who are very, very immunosuppressed or immunocompromised, you will use bactericidal drugs or bacteriostatic? Bacteriostatic or bactericidal? Bactericidal. You are intelligent, good. So, we should write here a very important statement. penicillins and cephalosporins. Cephalosporins are very cidal for susceptible microbes. Am I right? Do you think it's difficult to remember? It's a very simple statement that penicillins and cephalosporins are very cidal for or very fatal for susceptible microbes. Not difficult to remember it. Can you remember it all your life? Okay, good. I will ask you a question. Can you tell me the antibiotics other than penicillins and cephalosporins which are also bactericidal? Tell me at least 4 antibiotics other than penicillins and cephalosporins which are bactericidal. Is it important to know or not?
Sure.
Yeah. Can madam? You don't want to tell. She hides her knowledge. You are also same? Who will tell me? Drugs, you are doctors, my friends. Practicing doctors.
Azithromycin?
Is azithromycin or what you are saying? Look, my question is, we want to know, look here, we want to know 6 bactericidal antibiotics. 2 I am telling you, penicillin and cephalosporin. Remaining 4 you will tell me.
Vancomycin?
Okay, vancomycin. Very good. Yeah. Rifampicin, no. Yes. We'll talk about that. Is actually ciprofloxacin. Okay, let me tell you. That is already written on the board. You just find it. It's there. Look. P for penicillins. C for cephalosporins. A for aminoglycosides. V for vancomycin. F for fluoroquinolones, and M for metronidazole. That's so easy. Penicillin and cephalosporin are very cidal for microbes. And you know all the 6 groups. Penicillins, cephalosporins, aminoglycosides, vancomycins, fluoroquinolones and metronidazole, all of them in proper doses are bacteriocidal. Let's have a break now. Right, now in the last video we basically discussed about the mechanism of actions of different drugs which act on the bacterial cell wall synthesis process. And especially we discussed that penicillins and cephalosporins and other beta-lactam antibiotics are inhibiting the transpeptidation step, right? So that transpeptidation step is not done and peptide crosslinks are not made in the bacterial cell wall, and cell wall is not synthesized properly. Is that right? And at the same time we talked about that can in the presence of cephalosporin then penicillins, there is autolysin inhibitors are themselves inhibited and autolysin process become more fast, and that also contribute to the bactericidal action of these drugs, right? Now we will going to detail about the different groups of penicillins and mechanisms of resistance and some important pharmacokinetic facts related with penicillins. Just review a little. In the very first video of penicillin, you remember we talked about the different groups of penicillins. We'll just review that briefly and then we'll proceed forward. So in the penicillins, what were the main group of penicillins? You remember there were penicillins which were the narrow spectrum and there were wider spectrum. You can say penicillins are narrow spectrum and there are just wider spectrum penicillins. And narrow spectrum penicillins there were 2, mummy penicillins and papa penicillins. There were natural penicillins and there were penicillin, yes, very good, penicillin G and penicillin V, very good, right? And in case of These were, I think we talked about housewife penicillins, right? They are moderately smart. They are not mucho smart, but we can say they are right. This is the natural penicillins, right? And then we had penicillins which were really, yeah, rather it should be papa or grandmother penicillins, right? Okay, this should not be up, it should be here. These are very heavy weight, right? Now these penicillins are very heavy weight, they cannot enter into the porins, and they are not effective on gram negative at all, and they are not effective in many other bacteria because they cannot pass through the layers of cell wall and they cannot reach to the penicillin binding proteins to do their action. But they can successfully reach to the penicillin binding proteins present on staphylococci. Is that right? And special thing about them were they were resistant to the action of penicillinases. You remember? Or beta-lactamases. We talked about they are having a little bit heavy group. You remember their structure? The R group was little heavy and protecting and beta-lactamase resistant. Right? So this is the Papa group, and this Papa group is very, very resistant. Right? This is the only group which is resistant. In the family, you can imagine there's Papa, there's housewife, mommy, and there are two young, beautiful girls. So only Papa is resistant against the penicillinase action, and his basement cannot be damaged. Is that right? So what we can say, what were the groups here? Can you tell me? Very good. Nephicillin, methicillin, cloxacillin, decloxacillin, flucloxacillin, which is less used now, right? So nephicillin, methicillin, nephicillin, cloxacillin, decloxacillin, and oxacillin. So all of them are right strong. And then we talked about the wider spectrum anti-penicillins, and in that group we put the two. There were, yes, the SMART model, right? SMART, which were called extended spectrum. Extended spectrum, which was covering more gram negative, and we can imagine them, okay. Right, these are the SMART one, and these extended spectrum, right, they could go through the porins of many gram negative. What were the members here? Amoxicillin, and ampicillin. But do you think they are protected? No. So they are susceptible to the action of? Yes, they are susceptible to the action of penicillinases or beta-lactamases. These are also susceptible to the action of beta-lactamases. But this Papa type is not susceptible. It has a big R group which protects it. Okay, it's just to memorize it. Is that right? And now we come to the most smart, right? Which were the most smart? The super model. This was the model, and here is super model. Right? The super model has a big trouble. She is not protected at all. Is that right? She is too smart, and right, and she can pass through even, what is that? Porins of many gram negative, right? Like even can go through, yes, pseudomonal outer membrane. But you had to remember, this one was not able to pass through the pseudomonal outer membrane because it was heavier. That is too smart, right? Due to this reason, these are also called anti-pseudomonal Pseudomonal penicillins like carbanicillin, piperacillin, ticarcillin, azulocillin, mesalocillin. Now, if you look at this board, there are three female groups: natural penicillins, extended spectrum penicillin, and anti-pseudomonal penicillin. Only one is the papa, anti-staphylococcal. Is that right? So what you have to remember, that whenever you are giving this papa group, right, or grandmother group or papa group, this group does not need security of anti-beta-lactamase group. With these drugs, you don't need to give clavulanic acid, you don't need to give sulbactam, you don't need to give what? Yeah. This housewife group, which is basically very susceptible to beta-lactamase activity, actually you can look at all three of them are females. This housewife, mama group, and two daughters, one model, another supermodel. All of them are effective, susceptible to the action of beta-lactamases. So, about this mama, she is not bothered much. So, we don't provide much security to her, you can understand. But for these two girls, we have to have much security, bodyguard molecules. So, usually with this group, we add security of, special security of what? So that there is no undue action to them. What is this molecule? Yeah, they are anti-beta-lactamases, right? You know, there are basically three of them are available, which are commonly used: clavulanic acid, sulbactam, and tazobactam. Is that right? And this security, bodyguard, should be with her also. Is that right? So many times when we use, again, very easy to remember, there is a family of penicillins. There is papa, mama, and two beautiful daughters. Where you need the maximum security? The daughters, everyone understand it, isn't it? Mama doesn't bother much and papa is really papa. You get it? So, this is about the basic concepts related with the family of penicillins. Now we talk about the resistance against the penicillin, the concept of resistance against the penicillin. When we talk about what are the mechanisms of resistance, as doctors came up with the penicillins, bacteria also gradually evolved and they brought up different defense mechanisms against our ruthless attacks of penicillin and cephalosporins. What was the most common? About this defense mechanisms in bacteria for the resistance against beta-lactam antibiotics are resistance. There are two types of resistance. There is a natural resistance and there is acquired resistance, natural resistance. For example, some microbes are naturally resistant to the action of penicillins, and some of them are initially susceptible to penicillin and beta-lactam antibiotics, and later on they got resistant. They acquired the resistance. Now, first of all, we'll talk about the natural resistance. There are some microbes which are naturally resistant to the action of penicillins and cephalosporins and other beta-lactam. Can you tell me some microbes which are resistant to penicillin? Yes, ma'am, please. You don't know any. Why don't you tell me all fungi, all virus, all human cells? Did you kill human cells with penicillins? Why? Because none of them have peptidoglycan. So all those microbes which do not have peptidoglycan, or all those cells, either human cells or animal cells or microbe cells, all the cells which do not have peptidoglycan, can beta-lactam antibiotics damage them? So it's such an easy answer, right? So there's natural resistance in, let's suppose, all those microbes which do not have peptidoglycan. No, don't use the word cell wall, because fungi have cell wall, but they are not made of peptidoglycan. Fungi have cell wall which is made of chitin. They are made of chitin, right? Or for example, there is what is this funny bacteria Mycobacterium tuberculosis. That is a cell wall which has an outer layer of mycolic acid, and mycolic acid does not allow the penicillins to go into deeper. They're naturally resistant. So natural resistance is seen, you can say the point which you have to write, the microbes without peptidoglycans, or cells, yes, cells without peptidoglycan molecules, glycan. Now what are these? Of course, number one, within the bacteria, notable exceptions are mycoplasma. I told you in previous lecture that mycoplasma does not have a cell wall, and if someone does not have a cell wall, can you damage the, yeah, it is just like that. A woman does not have hair, can you cut her hair? So simple, is it right? So mycoplasma does not have a cell wall, right? So you cannot damage the mycoplasma by cell wall active agents or penicillin, beta-lactam antibiotics. Then there can be in the bacteria like mycobacteria, lepri or mycobacteria tuberculosis. They are having a very thick layer of outer mycolic acid. This is a very waxy layer. It does not allow the penicillins and cephalosporins to go in, and it does not, there is not much peptidoglycan to be acted upon. Then there are chlamydia. Chlamydia are resistant to the action of penicillins. Why? Because book says it, or there is some reason for that. Because, very good. So Dr. Denise is telling you that basically in the life cycle of chlamydia, a component, some type of it multiplies intracellularly. Now you imagine, if bacteria is present within our cell, if bacteria is present within our cells, can penicillins enter in our cell? No. So can that bacteria be killed? No, it's so simple. Is that right? Then, of course, there are so many examples like fungi. Fungi have cell wall, but that is not made of peptidoglycan. So you cannot damage the penicillin or cephalosporins. So you understand that there are many microbes which are naturally resistant to the actions of penicillins and cephalosporins and beta-lactam. And of course, you must mention human cells, which is the most important point, that human cells cannot be damaged by penicillin. Why human cells are not damaged by penicillins? Because human cells do not have cell wall. They do not have peptidoglycan. And that is the reason why penicillins are so safe for us and so toxic to the susceptible bacteria. Is that right? So in these cases there is natural resistance. Then there are some bacteria which are having peptidoglycan, but still they are naturally resistant. The classical example is like Pseudomonas. They are naturally resistant to penicillin G and V. Right? They are many gram negative which are naturally resistant to natural and narrow spectrum penicillins. Why? As I explained previously, that many gram negative bacteria have outer membrane with very small porins, and natural penicillins or this mama papa cannot go through those porins. Is that right? So those bacteria are offering a natural resistance against natural penicillins and anti-staphylococcal penicillin. To understand it more clearly, you have to watch the previous videos. Is that right? Then there is acquired resistance. Is that right? There is acquired resistance, and this is what is making a lot of trouble to us. First of all, doctors came to know about that some bacteria started producing enzymes which could break down the beta-lactam ring. And you remember, these bacteria are said to be producing beta-lactamases. And if these beta-lactamases are destroying beta-lactam of the penicillin, then we were calling it penicillinases, right? So beta-lactam production, beta-lactam production. Now, let's suppose here is a bacteria, and this bacteria has the capability to produce beta-lactamase enzyme, beta-lactamase. It is not beta-lactam, it is beta-lactamase production. Thank you for correction. Now, Bacteria produce beta-lactamase. Beta-lactamase is an enzyme. It means it is a protein. If it is a protein, it should be translated from messenger RNA. It means there should be some DNA. So it means those bacteria which release beta-lactamases, they are having some genetic information to synthesize beta-lactamases. So that information may be present in the chromosome of bacteria. Bacteria have one chromosome or two chromosomes? Bacteria have one chromosome which is usually circular, right? So within this chromosome there may be some, you can say, genetic, some gene within this chromosome. There may be a gene which can make such messenger RNA which can be translated into beta-lactamases. Or in some bacteria, the genetic material coding for the beta-lactamases is not present in the chromosome. Rather, in some bacteria, look here, here is the chromosome, and chromosome of bacteria, and here is extra chromosomal DNA. What is this? Extra chromosomal DNA. Extra chromosomal DNA is called, yes, extra chromosomal DNA is called plasmid. Have you heard of plasmid? Some bacteria have plasmids. Plasmids are extra chromosomal genetic material which can auto-replicate. It can replicate independent of the bacterial chromosome, because all the genes which are essential for survival of bacteria, they are present in its chromosome. And if bacteria receive a plasmid, plasmid may provide new protein molecule to the bacteria and provide new characteristics to the bacteria. So actually beta-lactamase producing gene may be present in chromosome or it may be present in plasmid. Is that right? Now you may be thinking why it is important to know. Let me tell you. Actually, if beta-lactamase producing gene is part of the chromosome, right, of course this bacteria will produce beta-lactamases, and this bacteria and all its progeny cells, derived cells, the cells which are produced by the proliferation of this bacteria, will be resistant to action of beta-lactam antibiotics. Is that right? But do you think this bacteria can gift its chromosome to the other cell? For example, if this is E. coli suppose, or Staphylococcus, can it give this chromosome to Klebsiella? No. Now you imagine there is another bacteria which come to your body, or in this bacteria somehow come to your hospital, and this bacteria was having a plasmid, and this plasmid was having a gene to produce beta-lactamases. Now this plasmid mediated, what is this? Plasmid mediated production of beta-lactamases is dangerous. You know why? Because this bacteria, when it is present in patient number 1, this bacteria is multiplying and making lot of plasmids, and then this bacteria may give these plasmids to many other bacteria. So it means that this bacteria has a great secret. There is a great secret of protecting against the beta-lactam antibiotic which is locked in plasmid, and bacteria keep on proliferating itself or surviving itself, and through conjugation process plasmid may go to the other bacteria. You know what is bacterial conjugation, ma'am? You know something about bacterial sex? You people are not bothered about bacteria. Yeah, bacteria are very sexy. Yeah. You doubt it because you are a human being, so you don't consider bacteria as a partner. But bacteria are very sexy. Look at it. Let me make a bacteria. You don't make fun of it. Bacteria are very sensitive to the negative comments. Look at this bacteria. And there is another bacteria here. This is bacterial chromosome. Here is bacterial chromosome, and here is also bacterial chromosome, right? what happens that, let's suppose this bacteria has a plasmid. What is this? Plasmid. And on this plasmid there is one gene which can code for the beta-lactamases, and there is one more gene here. And when this gene expresses, special proteins are made in this bacteria. And when this bacteria makes special proteins, there's something very secret. Those proteins will come to the surface of this bacteria and a small tube will start growing. Don't get emotional, but it is true. A small tube will grow and it will touch the membrane of other bacteria. And this bacteria will receptively provide a hole. Yes, this is true. And then what happens, right, that this is a gene which gives the order to produce sex pilus. It P's for pilus, right? So sex pilus is produced and then this plasmid open and then it passes through this and reaches there. And now this bacteria was resistant, and eventually when plasmid have gone to the other bacteria, then other bacteria also becomes resistant to the action of penicillins because it is producing beta-lactamases. So this is an example of plasmid mediated resistance. So resistance may be plasmid mediated, it is dangerous. Why? Because one bacteria can pass the plasmid to many other bacteria and resistance will spread rapidly. But if resistance is chromosome mediated, can bacteria gift its chromosome to other? No, because if it gives its chromosome, this bacteria will die, right? So when bacteria are living and having the plasmid, and one plasmid may convert into 100 plasmids or many plasmids, and then plasmids, bacteria is happy to have what? Conjugation. This sexy activity is called bacterial conjugation. It's a conjugation, right? So by conjugation process, bacteria keep on passing plasmids to other friendly and partners, and then all the group become resistant to beta-lactam antibiotics because all of them are beta-lactamase positive bacteria, right? So this, but do you think any bacteria will love to give its chromosome to others? No, right? But sometimes what happens? Bacteria die and its genetic material fall out, and some other bacteria come, remove a piece of it and take it away and become resistant. But that is less often activity. Conjugation is far more common, far more efficient to transfer the resistance from one group of bacteria to many other group of bacteria. Am I clear? Right? That is why plasmid mediated resistance mechanism, once they come to your hospital, they will spread very rapidly. But chromosomal mediated will spread slowly. And actually bacteria, beta-lactamase production in some bacteria is chromosome mediated, and other it is plasmid mediated. Am I right? No problem into this? Okay. And already you know it that when beta-lactamases are produced in gram-positive bacteria, they secrete the beta-lactamases in extracellular fluid, and beta-lactamases or penicillinases spread into fluid around the bacteria. But gram-negative bacteria secrete but concentrate the beta-lactamases or penicillinases in their periplasmic space. So antibiotic really reached there, and once antibiotic enter into periplasmic space, it cannot run back. It is caught by a big group of beta-lactamases. Am I clear? Right? So this was something about acquired resistance, that many bacteria, they produce the beta-lactamases and then they start doing the resistance mechanisms. And now we come to another thing, another type of resistance which may be acquired. And what is that? Less often, what really happens that you have suppose 1 million bacteria and you are exposing them to the beta-lactam antibiotics. You know, bacteria undergo spontaneous mutations. So some out of those millions of bacteria, 1 or 2 bacteria alter the genetic material to produce the porin, and they make the porins tight. If they make their porins tight, they become resistant to penicillins. You are understanding? So this is another way of acquired resistance, that by altering the porins, some bacteria may get or beta-lactam antibiotics. Am I clear? Then another way, of course, if bacteria, if you give with the penicillin clavulanic acid, will that help the problem? No. Problem is in the porin. But in this case, when you have beta-lactamase positive bacteria, usually what we do, we give either papat group, which is protected against which does not, it cannot be attacked by beta-lactamase, or we give these smart girls with the bodyguard. But in this case, if a bacteria is resistant against the penicillins because it has altered its porins and they are very, very narrow, right? Now even you give penicillins with the bodyguard, will that help? No. Is that right? You understand? Okay. Then we come to another mechanism. So what was happening? Bacteria can do resistance either by destroying the antibiotic, beta-lactam ring, or they can become resistant by reducing the entry of the bacteria. Become really naughty. Penicillin keep on entering and they out. They use energy dependent mechanism to kick the penicillin in the ass and out of their near environment. Efflux pump. Especially these efflux pump are present in gram negative negative, right? Out. Concentration to really effectively bacteria efflux pump. But when you use penicillin and cephalosporin too much, more efflux pump, they survive more and others are dead. So all the environmental benefits go to them. and resistance spread in the environment. Are you understanding me? And then become the master plan of bacteria. The master plan of bacteria. Master plan is that, actually let me tell you, originally most common mechanism of bacterial resistance is production of beta-lactamases. So we were very happy when we made which penicillin? Papa penicillins. They protect their beta-lactam ring. So Papa penicillins were killing the bacteria very ruthlessly. Even those staphylococci which were having a lot of penicillinase, then nephecillin, methicillin, cloxacillin, dicloxacillin and oxacillin, they were very effective in those staphylococci which were producing beta-lactamases because they were protecting their beta-lactam. Is that right? Especially the most important in this group was methicillin, right? And then they were derivative of that. So when doctors covered pharmacist produced the methicillin, right? They were very happy because all those staphylococci which were producing a lot of beta-lactamases and killing our patients, and doctors are really in trouble. The doctors are very happy that we were giving methicillin and then its related drugs, and even those staphylococci which were resistant were killed. So it was a wonderful drug. But then life is life. Eventually you get another bad news. Some bacteria really got nasty. Right? They came with a very clever plan. What did they do? That was the last plan of bacteria, and these days we are suffering with that. What bacteria did, look at this bacteria, right? And in this bacteria, of course, what are these proteins? Penicillin binding proteins. What are these? Transpeptidase enzymes, right? And there are others also. Now, what did we do? That we bring the what is this? This is methicillin or related. And if this bacteria was producing beta-lactam, do you think beta-lactamases, will this be destroyed? Methicillin should be able to kill this bacteria. Should be, isn't it? But we were surprised. A new group of bacteria emerged, and those staphylococci were resistant even to the action of methicillin. So then we started thinking these methicillin resistant bacteria are having some different type of resistance mechanism, because it cannot be resistance due to beta-lactamase production, because methicillin is not sensitive to the action of beta-lactamase. And these methicillin resistant bacteria, especially staphylococci, they started really killing the patients. And doctors were very upset. In any hospital they find staphylococcal infections which cannot be controlled by these, right? They send the bacterial sample to the laboratory and they try the methicillin, and in the presence of methicillin in the petri dish, the staphylococci keep on growing, and they got very upset, and they said this very dangerous bacteria, this was called Mr. Sa, methicillin resistant Staphylococcus aureus. Even to these bacteria, you give these things with the bodyguard, can they work? No. What was the trick bacteria played with us? Actually, the genes, there was a gene which was giving order how to make, what is this? Transpeptidase. This gene got mutant, and this gene made altered, what is this? Altered transpeptidase enzyme, and or we can say these mutations in genetic material of bacteria produced altered penicillin binding protein or altered what? Transpeptidases. Now beta-lactam ring cannot fit on it. Now you come with penicillin G, or you come with methicillin, or you come with this or that. Can we kill this staphylococcus? No. So we say this is a dangerous staphylococcus, even which cannot be killed by methicillin, and we call this organism methicillin resistant staphylococcus aureus. What are these? Methicillin resistant staphylococcus aureus. What is the special mechanism of this resistance? Alteration of penicillin binding protein, right? That is why that on these staphylococci vancomycin is effective, because vancomycin, you remember in previous lecture, vancomycin will not allow the new NAM-NAG-PEP unit to bind with the existing glycosylation reaction. Is that right? So when you give vancomycin, right, for example, I'm a staphylococcus which is producing beta-lactamases, as well as I have altered my penicillin binding proteins. Now, can you kill me by penicillin or cephalosporins? No, because I have altered the target protein to which the antibiotic work, and transpeptidation step cannot be inhibited. But if you are clever, you give me vancomycin. Vancomycin will go and will not allow the newly secreted units of NAM-NAG unit to bind with the existing cell wall components, and cell wall will become weak. That is why methicillin resistant staphylococcus aureus are sensitive to vancomycin. And then there are bad news. Bacterial came up with the challenge. The worst news which we have about the staphylococci are some staphylococci have altered those enzymes also which were doing transglycosylation, and now vancomycin cannot bind with them, and they are methicillin resistance as well as vancomycin resistant. But you know, our cerebral cortex is more than bacteria. We came up with a new different way to kill those bacteria. We give them ciprofloxacin, and these fluoroquinolones and ciprofloxacin, they go into bacteria and digest away all the, I will tell you how in later lectures, how fluoroquinolones enter into bacteria and eventually bacterial DNA is fragmented. This is not the antibiotic which fragments the DNA. In the presence of fluoroquinolones, bacterial enzymes do fragmentation. How they do, we'll talk it later, right? But one thing which you have to come to know, that this is the super bug with super resistant, and this is called by another resistance mechanism by alteration of penicillin binding protein. This mechanism was originally discovered in methicillin resistant staphylococcus aureus. Now this is also discovered to be present in Streptococcus pneumoniae. You know, the most effective drug for Streptococcus pneumoniae was penicillin G. Of course, every doctor knows, isn't it? Penicillin G is a killer to the Streptococcus pneumoniae, because doctors were very happy. Why? Because Streptococcus pneumoniae were not producing beta-lactamases. So we could give the penicillin G and kill them. Is that right? Now the new strains of, resistant strain of pneumococci are there, Streptococcus pneumoniae, which are resistant to penicillin G. Is that right? Why? Because pneumococci has altered their penicillin binding proteins. So even though alteration in penicillin binding proteins was originally discovered in methicillin resistant staphylococcus, but now we know there are many other bacteria which are using the same strategy, so that our beta-lactam antibiotics fail. The very dangerous changes in the Streptococcus pneumoniae, which is a very common cause of pneumonia, right? And previously we could give injections of penicillin G and very effective response. Now sometimes we are in trouble. Then another bacteria has done also the same thing, and that bacteria may be resistant to, they have altered their penicillin binding proteins and other proteins to which the vancomycin could even bind. What is that bacteria? Have you heard of Enterococci? Enterococci. Many Enterococci are altering their penicillin binding proteins, they're also getting resistant to beta-lactam antibiotics. Is that right? So what are the 4 mechanisms? Number 1, destroy the beta-lactam antibiotic before it reaches bacteria. Before it enters into bacteria, you destroy it by beta-lactam agents. Number 2, tighten the porin, don't allow it to enter. Number 3, if it enters, then you throw it out. It's really a very disrespectful way that antibiotic come happily and you throw it out and again come in and throw it out. Is that right? So, and the last but not the least, very important, okay, let the antibiotic come. Don't destroy it. Let it enter. Don't throw it out. But it cannot bite on penicillin binding proteins because they have become altered. Is that right? So this was some discussion about the resistant mechanism which are present in against the penicillins. Now let's talk about few important points related with pharmacokinetics of penicillins. I will not go into detail, but there are some important points we must discuss about the penicillins. All of you know that some penicillins are given orally and other penicillins can be given parenterally. Is that right? Some penicillin can be given orally and the others which can be given parenterally, intravenously or intramuscularly, and there are still other penicillins which can be given orally as well as parenterally. Parenterally mean not through GIT, right? Now, the penicillins which are given, which are available oral, which can be given orally as well as parenteral, which are given only orally, write it down. Penicillins which can be given only orally, right? Can you tell me the penicillins you must be knowing which are given? Yeah? Ampicillin is available in injection form, ma'am? No, it is. Duh. Okay, ask any bacteria. Yes? I think penicillin V. Right? Why don't you tell me penicillin V? Penicillin V, that is given orally because it is acid stable, but it is used very less commonly, usually for the mixed infection in oral cavity, right? Or penicillin V is also used in children with a history of rheumatic fever to protect the further attacks of Streptococcus, beta hemolyticus, Lancefield group A, rheumatogenic strain. Is that right? Even though these days we prefer to give them intramuscular injections of benzathine penicillin, right? We'll talk about that later. So oral, some penicillins which are available only to be given orally, that is penicillin V as well as amoxicillin and amoxicillin with clavulanic acid, amoxicillin plus clavulanic acid like augmentin, and carbenicillin in special form which is called indenyl carbenicillin. You remember anti-pseudomonal? These are which are specially given orally, right? Then there are some which are specially given parenterally, right? So A group is which is specially given orally. I'll tell you B group of penicillins which are specially given parenterally or intravenously. Now in this group there is ticarcillin, carbenicillin, piperacillin. So it means straight away these three, which one? Anti-pseudomonal. You remember carbenicillin? Carbenicillin, you know James Bond action. James Bond come on a car, it has a pipe and throw the tick sometime. So carbenicillin, piperacillin, and ticarcillin. So these are anti-pseudomonal and penicillins which are which cannot be given orally. There's only one out of this which can be given orally is carbenicillin with indenyl group. Is that right? All of them are given parenterally. Or if with these drugs we have added the tazobactam or sulbactam or clavulanic acid, again they are given parenterally. Is that right? They can be given parenterally. So ticarcillin, carbenicillin, piperacillin, or of course ampicillin with sulbactam. Ampicillin plus sulbactam. You know ampicillin was extended spectrum here. So it needs to be protected, right? Carbenicillin, then piperacillin and ticarcillin, they have also protective molecule which are anti-beta-lactamases. So ampicillin, the sulbactam, is only available in parenteral use, intravenously or intramuscularly. Is that right? Now, what about the remaining penicillin? Remaining can be given, are available both oral as well as parenteral. Is that right? Okay, one more point which I will tell, that when you are giving penicillin orally, I told you previously, penicillin B is acid stable because its R group protects the beta-lactam ring from the attack of acid. Penicillin G is not much acid stable. I told you that stomach acid will destroy the penicillin G because penicillin G is sensitive to the action of the acid. Is that right? Then we come to the penicillins which are available in depot form. Penicillins which are available in depot form. Which can be given one injection which keep on working for a long time. There are some penicillins which are injected into intramuscular, deep intramuscular injection, and from there active penicillin is released very gradually, and it's very long acting penicillins. Which are these? Pardon? The procaine penicillin, penicillin, and what is the other? Benzathine penicillin. So, if you add benzathine with penicillin or procaine with penicillin, then penicillin stick to the procaine or stick to the benzathine. And in this combination form, penicillin is released from benzathine or from procaine molecule very gradually. So it keep on working. For example, benzathine penicillin can keep on releasing the penicillin for up to 3-4 weeks. That is why in patient with rheumatic fever, children who have a susceptibility to rheumatic fever, every month we give one deep intragluteal injection of benzathine penicillin. Am I clear? Okay, I just want to know, this penicillin which is sticking to procaine or to the benzathine, which is which penicillin? Mama penicillin, Papa penicillin, or model penicillin or supermodel penicillin? No, look, it is being released gradually. Which penicillin is complex with procaine or benzathine to get the depot form out of these 4 groups? It is penicillin G. So yeah, you are very right. That penicillin G is complex with procaine, or normally penicillin G has a very short half-life. But penicillin G, when it is complex with procaine or with benzathine and then given deep intramuscularly, it keep on releasing from there for very long time. Is that right? So these are 2 depot penicillins. About the absorption of penicillins from GIT, right? Especially I am interested to discuss this issue, amoxicillin and ampicillin. Amoxicillin and ampicillin, which is better absorbed from GIT? Very good. So it is from GIT, right? And here you have amoxicillin, MO, and here you have penicillin. So amoxicillin can be absorbed, complete absorption from the GIT to the blood. Penicillin from GIT absorption is very poor, most of it moves forward. Is that right? It is good or bad? Look, first let me put the question. Amoxicillin absorb mostly from the GIT, right? It is good or bad? It is good and bad. Let me tell you why it is good and why it is bad. If you are treating some infections in which antibiotics should absorb from GIT and go to the blood, then amoxicillin is wonderful. For example, if patient has amoxicillin susceptible bacteria in the throat or in the ear or in some other part of the body, he can take the amoxicillin orally and it will be very good absorption and it will go to the systemic circulation and find where is the culprit bacteria and kill it. But it is bad also in one way. You know how? If you are having bacteria in the GIT, for example, you have salmonella or shigella and playing havoc in your GIT, you give them amoxicillin and it does not stay in GIT and gets absorbed. Can it eliminate salmonella or shigella? No. So it is good and bad. It is good when you are treating those. It is good that it is absorbed because for systemic, when we require the amoxicillin systemically, but amoxicillin fail on the GIT tract infections. Am I clear? Opposite to that, when we talk about ampicillin, this was what? Amoxicillin, ampicillin. Ampicillin is poorly absorbed from GIT. So when we really want to give ampicillin for systemic infection, we prefer the injections. But if someone has a heavy infection in the GIT like Salmonella, Shigella, and which is sensitive to ampicillin, we can give safely oral ampicillin, and ampicillin will keep on going down and down in GIT with poor absorption and stay in GIT and damage the bacteria. So you understand? So both of these antibiotics, amoxicillin and ampicillin, have advantages and disadvantages of this has a good absorption from GIT, this is poor absorption from GIT. Any question up to this? Another point which I want to mention, these papa antibiotics. What are these papa antibiotics? Methicillin, which is not used these days, but nefcillin, cloxacillin, dicloxacillin, oxacillin, these are anti-staphylococcal antibiotics. Many of them are available in oral form, but you have to be very careful that their absorption is affected by the presence of food. They should be given when patient is empty stomach, either 1 hour before food or 2 hours after food. 1 hour prendially or 2 hour post, right? So they should be preferably given, papa. Food should not be there, it needs its own independent activity to be absorbed. Is that right? Then once these antibiotics are absorbed, of course they will go to circulation, and in the circulation, how they get distributed in the body. Suppose this is your general circulation, here was your GIT absorption which we have been discussing, is that right? And then once these penicillins are present in circulation, how they are distributed. Remember, penicillin molecules are not so lipid soluble to pass through our cell membranes. Due to this reason, intracellular bacteria are not attacked by penicillins. Penicillins are very well distributed in extracellular fluid. They are distributed in the blood, as well as from the blood they leak out into interstitial fluid. They also leak out into many other body fluid. About the meningitis or encephalitis, when you require the penicillin, there is a blood-brain barrier. Normally, penicillins don't cross blood-brain barrier. But when there is meningitis or encephalitis, right, blood-brain barrier is broken, because in inflammation, what happens? Chemical mediators of inflammation are produced, and endothelial cells of cerebral capillaries shrink. Blood-brain barrier is produced by, you know what is the mechanism of blood-brain barrier, or you don't know it? You know it or not? Hurry up. You want to know or you don't want to know? Okay, you want to know. Let me tell you what is blood-brain barrier. Look, here is your central nervous system, right? Here are your neurons, right? And here is, suppose your blood vessel passing, this is the arterial side and this is the venous side. And let's suppose here are the capillaries. And these are which cells? Endothelial cells. This is cerebral capillaries. Now from where the blood-brain barrier concept came? Actually, there was a doctor who was injecting the cats, C-A-T-S, cats with a special color called I1 blue. And after that he was very ruthless, I think sadistic person. He will kill the cat and look in which part of the cat the dye I1 blue has gone. He was surprised that I1 blue, which injected in the blood of the cat, it will go to the all part of the cat but will not enter into the brain. Brain of the cat will not turn blue. He said there is some blood and brain barrier. That was the original concept. There is some barrier between the blood and brain, and every molecule from the blood cannot enter into brain. Later on we found that this barrier does not allow many drugs. For example, this is a drug, penicillins. When they pass through the cerebral capillaries, they cannot pass through this and come into interstitial fluid of the brain. And they enter from arterial side, pass through the capillaries and go out through venous side. and they do not enter into substance of the brain. So we say between the blood and the brain fluid there is barrier. This barrier is actually made by the very tight interdigitation of the endothelial cells. Brain, capillaries, endothelial cells are very tightly linked with each other. Let me tell you, if this is one endothelial cell, this is another endothelial cell. Actually, in the central nervous system, they are interdigitating very tightly, so drug cannot pass through this. But when there is inflammation, and of course in inflammation there are many chemical mediators of inflammation, and those chemical mediators of inflammation act on endothelial cell and endothelial cell shrink. When endothelial cells shrink, what happens? It opens the way for the larger molecule. So penicillins normally cannot cross the blood-brain barrier effectively, but when there is infection in the brain, blood-brain barrier becomes leaky. We call it becomes leaky, and then penicillins start entering into to the central nervous system. And as infection terminates, as inflammation goes down, concentration of chemical mediators become less, blood-brain barrier re-establishes, and then again penicillin cannot cross. So anyway, we are happy that penicillin can enter into central nervous system when they are needed there. Is that right? Another thing, penicillins can, same is true about the bone infections, that in the bones, also in deeper part of the bones, penicillins normally cannot enter. But when there is osteomyelitis or more infections in the bone, penicillins can enter. Penicillin can cross the placenta very effectively, right? And because they can cross the placenta, they go to the product of conception. And the good news is that they are not toxic to the developing embryo or product of conception. So they are not having any teratogenic action. Is that right? Then about the penicillin, one more thing is about their metabolism. The very good news is they are not metabolized much. So we don't need to remember how they are metabolized. Yes, once they enter into your body, eventually they go out of your body. It means they are excreted or eliminated from the body. Most of the time they go through kidney. Most of the penicillin go out through urine. Nephicillin, and with the nephicillin there is mainly it's the nephicillin which goes through the liver, right? But most of the penicillins go out through kidney. In the kidney, of course, there are nephrons. What are there? Proximal convoluted tubule, and this is the nephron, right? And here's the drop of urine. Now, penicillin freely filter, but only once they are filtered, they cannot be reabsorbed. So 10% of the penicillin go out into urine through the filtration process, right? But really, in this proximal convoluted tubular cells here, what are these cells? Proximal convoluted tubular cells. They are having very special pumps here, and these pumps are basically, these pumps are called organic acid secretory pump. What these pumps are doing, blood passes through this peritubular capillaries. When many organic acid, when they are passing through this area, organic acid when they are passing through peritubular capillary system and into this area, this pump will take and actively transport peritubular, from peritubular fluid, these pump in the basolateral membrane of proximal convoluted tubule actively transport the organic acid to the lumen of nephron. The same mechanism is also used by penicillins, and 90% of the penicillins actually bind with these pumps and go into nephron and eventually appear into urine. Now you may be thinking, why it is so important to know this thing? There's a very important fact. Let me make it a larger diagram so you understand. I just make one cell, one basolateral cell, and this cell is having here a very special type of pump. And what is this pump? This is active transporter, which will take the organic acid and eventually throw them into, transport them. Clear? Actually, like benzyl penicillin, penicillin G, it has a very short half-life. And if we want prolonged action, we give another drug. And along with the penicillin G or with other penicillins, you can give another drug, and that drug should come and start using this mechanism for excretion. The blue drug along with the penicillin goes and that occupies these transport mechanism. Do you think now penicillin can go really out? No. So this penicillin secretory mechanism is used by the blue drug and now penicillins will be going back to the body. So they will not be eliminated so fast and that will prolong the half-life of penicillins. Right, you tell me the name of the blue drug. No, procaine. Procaine was different, which was coming as in injection with penicillin, so that procaine will bind with the penicillin and release it slowly. That is probenecid. Have you heard of it? Probenecid. This blue drug is probenecid. So along with the penicillin, if you go give probenecid bind with the organic acid transport mechanism more strongly than penicillin and occupies those transporting mechanisms, keeps them busy. So penicillin doesn't have a chance to use that pathway to slip out of the body and they stay in the body for longer time. Is that right? And of course, like many things, penicillins also appear in the milk. Of course, only in the female usually. Right? Do you think it has any implication? Or just I said out of my personal interest? Yeah? Yeah, for breastfeeding. What is the importance of this concept? If mother is taking heavy doses of penicillin for her own infection, sometimes, not always, penicillin may be taken up through the milk by the baby, especially ampicillin, and baby GIT get loaded with the ampicillin and most of the bacteria on the baby GIT is destroyed and super infections may develop there and baby may develop severe diarrhea. But anyway, this is not so often. It is not having much clinical importance, but penicillins are also secreted in saliva. So if you really love someone and you are taking penicillin, you can provide the person with some oral protection against the bacteria. Is that right? So here we stop today. Next time we'll talk about adverse reactions related with the penicillins and then cephalosporins and other beta-lactam antibiotics. Is there any question? Class dismissed. So we continue our discussion about the penicillins, right? Mainly today we will be talking about the side effects related with the penicillins. But before we really start the side effects of the penicillin, I want to mention something that penicillins and aminoglycosides, if they are given together, right, their effects are, bactericidal effects are better. Why? Who can explain it to me? It's a very good combination for dangerous organisms that penicillins are given with, yes, plus aminoglycosides. Yes. Why this combination is good? Who is going to tell me? Yes, sir.
In penicillin, the cell wall, it's more easier to aminoglycoside go to the.
Very good, excellent, doctor. You are right that if this is the inner bacterial cell membrane, right? And here is your bacterial cell wall. This is bacterial cell wall, peptidoglycan cross links, and there are special transporters in the bacterial cell membrane which are basically working to, this is aminoglycosides like gentasin, amikacin, yes, tobramycin, there's so many aminoglycosides. Now aminoglycosides are basically actively transported through these membrane transporters into the bacteria. And if penicillins are there and if penicillins are damaging the cell wall, right, then what happens, that penetration of aminoglycoside up to the cell membrane become facilitated, right? So what really penicillins do, penicillins basically when damage the cell wall, and make the cell wall very weak, then drugs like aminoglycoside, they can more easily reach to the bacterial cytoplasmic membrane, from where they are more actively pumped into bacteria. In this way, aminoglycoside reach to their target site in the cytoplasm of bacteria more effectively, and their effects, bactericidal effect, become more. Is that right? So that is why penicillins can be combined and with aminoglycosides in more serious infections. But there is one thing, when you are combining penicillins and aminoglycoside, they should not be put together in one container. Why? Rather they why they should not be put into one container? Because penicillins are negatively charged, and aminoglycosides are positively charged. Aminoglycosides are positively charged, right? Because penicillins are negatively charged and aminoglycosides are positively charged, so they should not be put into one container for a long time, because then aminoglycoside will complex with the penicillins, negatively charged penicillins, and make insoluble, non-effective complexes, right? After this little point, now we go to our main discussion of today, that is about the adverse effects of penicillins. Now, when we talk about the adverse effects of penicillins, let's suppose here is your circulatory system, right? Here is your immune headquarter. Immune system, immune headquarters. Here is bone marrow house. Here is your, what is it? It is GIT, don't think of other things. Here is your GIT, and here is your beautiful, what is it? Kidney, and of course I believe you have central nervous system also. Now we will talk about side effects or unwanted actions or toxic effects of penicillins. Before we really talk about adverse effects of penicillin, you must know penicillins are one of the very safe drugs. They are very commonly used, they are one of the safest drugs, and they are so safe that their blood levels are not monitored. Is that right? We don't monitor their blood levels in the patients. What is the penicillin level? Is it going to be toxic or not? They are one of the very safe drugs, but still they have some important side effects, and one of the most important side effects are related with the immune system, right? And we call it hypersensitivity reactions. What are these reactions? Hypersensitivity reactions related with penicillins. Now, how do you define hypersensitivity reaction? What is your concept of hypersensitivity reaction? Any immune reaction which is tissue damaging is called hypersensitivity reaction. Any immune reaction in your body which is damaging the tissue is called hypersensitivity reaction, right? Now, what type of hypersensitivity reactions are seen regarding penicillins? Okay, Dr. Carlos is saying that penicillin produce type 1 hypersensitivity reaction. Do you think penicillins can produce type 2 hypersensitivity reaction also and type 3 hypersensitivity reactions also, or they produce only type 1 hypersensitivity reaction? Yes, Tito. Okay, do penicillins produce only type 1 hypersensitivity reaction, or can they produce type 1 as well as in some other patient type 2, and still some other patient it can produce type 3 hypersensitivity reaction? Answer is yes. In different patients, penicillin may produce different types of hypersensitivity reaction. So penicillin, this is the very basic thing you must know about the penicillins, that they have the capability to produce type 1 hypersensitivity reaction, as well as they have a capability to produce type 2 hypersensitivity reaction, as well as in some other patient penicillins may produce type 3 hypersensitivity reaction. As you know, type 1 hypersensitivity reaction is classically produced when against the antigen we produce IgE. What is that? In type 1 hypersensitivity reaction, this is also called immediate type hypersensitivity reaction. Sometimes what happens when penicillins enter into your body, right, some of the metabolites of the penicillin, the metabolite which most commonly produces penicillin hypersensitivity reaction is penicillinoic acid. Penicillinoic, what is that? That is penicilloic acid. This is one of the metabolite of penicillin. This metabolic breakdown of penicillin has a capability to bind with our proteins. It can bind with the human proteins. Alone, penicillin or its breakdown product are so small in molecular weight that alone penicillin or their metabolite cannot activate our immune system. That's very important. Penicillin or their metabolic products are so small in molecular weight that alone they cannot activate our immune system. But because some of the penicillin's metabolites are capable of reacting and making a complex with our proteins, and then after penicillin metabolite bind with the human proteins, then they, in some patients or some persons, they have a capability to activate the immune system. Is that right? It means penicillin molecules are like heptans. What are heptans? Heptans are the molecules which cannot activate immune system on their own, but they can activate immune system by complexing with our own proteins. Is that right? Now, when penicillin, right, activate our immune system, it can produce hypersensitivity reaction. Now, in some patient it will produce type 1 hypersensitivity reaction, in which case basically what is happening? IgE is produced. IgE antibodies are produced against the penicillin or their metabolites, and these IgE are loaded on the mast cells and basophils, right? These are anti-penicillin IgE molecules which are attached with the mast cells and the basophils. Now, in these patients, whenever penicillin molecule is introduced, that will activate the IgE molecules which are loaded on the mast cells, and mast cells will be activated, and naturally from the membranes of the mast cells membranes will be activated and they will release prostaglandins and leukotrienes. Then granules of the mast cell will release, yes, histamine and proteases, proteolytic enzymes, we damage the proteins of the tissue, and granules also release neutrophil chemotactic factor, eosinophilic chemotactic factor, and on prolonged activation, even mast cells and basophils genetic material is activated, and that may produce interleukin 1 and tumor necrotic factor. So what we can say, those patients who develop type 1 hypersensitivity reaction against the penicillin, what's wrong with those patients? That those patients have made anti-penicillin IgE, that is loaded on the mast cells and basophils, and when penicillin come across these IgE molecules, right, mast cells are activated and basophils are activated, and their membranes produce prostaglandins and leukotrienes, and their granules, cytoplasmic granules release histamine, proteolytic enzymes and different chemotactic factors, and even their genetic machinery of mast cells and basophil is activated to produce interleukin 1 and tumor necrotic factor, right? And all these things will, these different chemical mediators will act as, they will produce the type 1 hypersensitivity reaction. Is that right? Now, the most dangerous type 1 hypersensitivity reaction, most dangerous type 1 hypersensitivity reaction seen with the penicillin is anaphylactic shock. What is that? Okay, let's remove this nasty thing from here. Anaphylactic shock. The very good thing about penicillin related anaphylactic shock is it is very rare. That's the only good thing about it. It's not very common, but still you have to be very careful as a doctor. Is that right? That some patients, even though very rarely, some people on introduction with the penicillins may undergo anaphylactic shock. But remember one thing, that usually when we are going to give penicillins parenterally, we make a skin testing, right? We inject a very small amount of penicillin related compound in the skin and we see there is immediate type hypersensitivity reaction or not. Because if patient is having IgE loaded mast cells under the skin, as soon as you will inject the penicillin, within few minutes there will be some redness and swelling, right, in that area, and of course to those patients you will not give penicillins. And this type of reaction is immediate type because it appears within few minutes. Is that right? Patient is prior sensitized to penicillins. So classical example of this is anaphylactic shock, or most dangerous type 1 hypersensitivity reaction related with the penicillin is anaphylactic shock, in which mast cells around the blood vessels are activated and blood vessels dilate and blood pressure dangerously drop. Mast cells around the bronchial system is activated and bronchoconstriction occur. Mast cells in the GIT are activated and abdominal pain develop. Mast cells under the skin are activated and you develop rashes. So of course this is the most dangerous side effect related with the penicillin. Is that right? Then there are some other side effects related with the penicillin. Let's talk about the type 2 hypersensitivity reaction. A classical example of, first of all, you must know what is type 2 hypersensitivity reaction. Type 2 hypersensitivity reactions are those reactions in which immune system is activated against the antigens which are intrinsically present in the cell membranes and other tissue membranes. Again, what happens? Let me explain exactly how it happens. Let's suppose this is a red blood cell. The red blood cell. These are red blood cell. What is this? Antigens, which are normal RBC antigens on RBC membrane. Now, if a penicillin metabolite bind here with these normal proteins are altered. In some patients what happen, the penicillin metabolite bind with our normal proteins, for example in cell membrane proteins, and alter these cell membrane proteins. When these cell membrane proteins are altered, they are no more recognized as self protein. Our immune system failed to recognize these penicillin mediated altered RBC membrane protein as self protein. Right? Immune system sense them as foreign, and immune system may make antibodies against that. And if immune system is making antibodies against these altered proteins which are the part of the cell membrane, then of course antibodies will bind with these RBC membrane. Usually these are IgG, and then they may activate the complement and break down the RBC. Or these antibodies which are binding with the RBC membrane, they act as opsonin. On one side they bind with the RBC, on other side the Fc portion of these antibodies bind with macrophages and neutrophil and enhance the phagocytosis of RBCs, facilitate the hemolysis of RBCs. You are understanding? So this is what? Penicillin associated autoimmune hemolytic anemia. So in some patients, penicillin or some other drugs can produce hemolytic anemia. Now this hemolytic anemia is not IgE mediated, and it is not mediated, it does not involve the mast cell. So it is not type 1 hypersensitivity reaction. This type of reactions are called type 2 hypersensitivity reaction. So what did we learn? What did we learn? That some patients may develop IgE against the against the penicillin, and patient become vulnerable to develop type 1 hypersensitivity reaction or immediate type hypersensitivity reaction against the penicillin. But some other patients, right, they in that case penicillin metabolite alter some of our cell membrane proteins, and then immune system make antibodies specifically directed against that particular cell membrane proteins, and that specific tissue is altered, and that is called type 2 hypersensitivity reaction which does not involve IgE, which does not involve mast cells and basophil, and type 2 hypersensitivity reaction of this classical example is penicillin associated hemolytic anemia, right? Immune mediated hemolytic anemia, is that right? Then there's type 3 hypersensitivity also. Can you give me some example of type 3 hypersensitivity reaction? A patient who is given penicillin and he developed type 3 hypersensitivity reaction. Yes, doctor? I don't like to share your knowledge. Yes. Okay. Yes. The classical example of type 3 hypersensitivity reaction is that in your body fluids and blood, there are antigen antibody complexes circulating. We say they are immune mediated reactions. What really happens is that in some patients, penicillin or their metabolites are circulating for a long time, and immune system make antibodies against the penicillin molecules or against their metabolites, and these antibodies, anti-penicillin metabolites antibodies, make complexes within the circulation. So what happens? Sometimes it happens that against the penicillin molecule, IgG or IgM is produced, or against the penicillin metabolites, IgG or IgM is produced, and these IgG, IgM bind with the penicillin or penicillin metabolites in circulation, right? And then in this way, in the circulation, immune complexes are formed. These immune complexes may get deposited in multiple areas. As these immune complexes are circulating, they may get deposited in multiple areas. Number one, these immune complexes may get deposited, right, in blood vessels. In blood vessels at multiple area, when these immune complexes are deposited, they activate the complement, and complement may activate the neutrophil, right? So wherever immune complexes are deposited in blood vessels, complement mediated and neutrophil mediated damage will occur to that part of the vessel. So we say in type 3 hypersensitivity reaction, the very special damage is vasculitis, inflammation of the vessels. So there will be evidence of vasculitis, vasculitic lesion, vasculitis, right? So now classically there's different types of vasculitis, how they clinically manifest in many different ways. When immune complexes are deposited in the blood vessels under the skin, the multiple vasculitic lesions under the skin, the small blood vessels under the skin undergo inflammatory damage and you develop multiple small rashes. So there may be rashes. Vasculitis may lead to, yes, skin rashes. Then if immune complexes get deposited in glomerular structures and activate complement and neutrophil there, that may produce glomerulonephritis, which will clinically present as proteinuria and even hematuria. Is that right? Then if these immune complexes get deposited in synovial membranes, that may produce polyarthritis. Polyarthritis. If these immune complexes get deposited, yes, in pericardial membrane or pleural membrane, that may produce pericarditis or pleuritis. Pericarditis or pleuritic inflammation, pleuritis, right? And if these immune complexes, many of these are trapped into lymph node, you develop generalized lymphadenopathy, right? And of course, when there are so many immune complexes, circulating immune complexes getting deposited into the skin, deposited in glomeruli, depositing in the synovial membrane, depositing in pericardium or pleura. So all these areas, complements and neutrophils and macrophages are activated, and these inflammatory cells may produce interleukin 1 and tumor necrotic factor, which may act on hypothalamus, and patient may develop fever. And along with the fever, patient may develop malaise. Is that right? So this type of reaction, all these reactions are called type 3 hypersensitivity reaction. Type 3 hypersensitivity reaction occurs usually after the injection of penicillin. They don't occur immediately, remember. Type 1 hypersensitivity reaction develop immediately. But type 3 hypersensitivity reaction develop after many days, sometimes 7 to 12 days after injecting penicillins, right? So again, if someone is given penicillin and immediately his blood pressure starts dropping and immediately rashes develop within few minutes and bronchoconstriction, difficulty in breathing, dyspnea, it is type 1. And if someone has been given penicillin and after that he develop autoimmune hemolysis, this is type 2. And if someone has been given penicillin, let us suppose injection of procaine penicillin, and after 7-8 days he developed multiple rashes with polyarthritis and glomerulonephritis with proteinuria and hematuria and chest pain due to pericarditis or pleuritis and generalized lymphadenopathy with fever, malaise and anorexia. This is an example of which type of reaction? Type 3. Type 3 reaction may also produce angioedema. What is angioedema? This is an example in which patient may develop after getting penicillin, after a few days patient may develop severe swelling of the lips, patient develop his own lip swelling, swelling of the lips, swelling of the tongue and periorbital swelling, right? We call this condition angioedema, right? So these are different types of allergic reactions which may be seen with the penicillins. Usually 5 to 10% people who are given penicillin may complain about different type of penicillin reactions, but again it's worth remembering the most dangerous hypersensitivity reaction related with the penicillin is anaphylactic shock, and thank God it is the most rare one. Am I clear? Any question after this? No. Then a very special mention of ampicillin related maculopapular rashes. Doctor, you have heard about it? That people who are given ampicillin after some time they may develop maculopapular rash all over the body. That is called ampicillin associated maculopapular rash. The point which I want to tell you, the most of the ampicillin associated maculopapular rash, macules and papules, are not hypersensitivity reaction. They are not IgE mediated, right? That is direct toxic damage of ampicillin in skin. Why it is so important to know? It is so important to know because if someone has a history of ampicillin related, for example, you give the ampicillin to someone and he develops after a few days ampicillin related maculopapular rash, if you know that that is not hypersensitivity, that is simple toxic reaction, you can continue ampicillin and after a few days they will disappear. But if any reaction occur severe hypersensitivity like type 1 hypersensitivity or type 3, of course you have to immediately stop the drug. Is that right? So you have to remember that most of the ampicillin related maculopapular skin rashes are not hypersensitivity in nature, they are simple toxic reactions. Am I clear? And other situation. There is, okay, I am going to make a diagram here. This is a person and here is another person, right? I hope you understand what's going on. What's going on? You have general knowledge, okay, I'm impressed. Now, some people's, there is a special viral infection. If you are having that viral infection, okay, I will give you a more simple example. There is a special type of viral infection. If you get 100 people with that viral infection in this town, if you get 100 people in your hospital with that specific viral infection and give everyone ampicillin, everyone will develop maculopapular rash. What is that virus? This is very important. There is a viral infection, and if you give ampicillin in the presence of that viral infection, the development of maculopapular rash, of course, in the skin goes up to 100% cases. And this diagram should remind you of that. Virus. No. What they are doing? They are kissing. Yeah, look at their, wow. No, do you thought their hands? Oh my God. Thank God you didn't think it's something else. Okay. Now it's okay. Hands are down, so it's clear. What is the viral infection which spreads by the kissing? And if you have that viral infection and you give ampicillin, right, the 100% chances patient will develop maculopapular rash. Epstein-Barr virus. I knew Carlos knows about that virus. Epstein-Barr virus, which just spreads by the saliva, right? In young adults, it's very common. And Epstein-Barr virus can spread from one person to the other person. What type of disease it commonly produces? Infectious mononucleosis. Have you heard of infectious mononucleosis? The organism related with that is Epstein-Barr virus. So any patient who has infectious mononucleosis, if you give the ampicillin injection, 100% chances, almost 100% chances, he will develop maculopapular rash. And these rashes are not hypersensitivity reactions. Am I clear?
So it's very common because cytomegalovirus and EBV, 90% of the population has it.
Epstein-Barr virus is,
90% of the
look,
population.
I say when this virus is producing infectious mononucleosis. When you are suffering with infectious mononucleosis and due to any reason you are given ampicillin, chances are almost 100% to develop maculopapular rash all over the body. Claro? Okay. Now, few more points related with this. Any question you want to ask about penicillin hypersensitivity reactions? No? Okay. Let's just.
If a person has a sensitivity for penicillin, can use cephalosporin?
Okay, this is a very intelligent question. He is asking that if a person has what? Allergy to penicillin, hypersensitivity to penicillin, can we use cephalosporin? Answer is, a good doctor will first know what kind of reaction is there. If you are having penicillin associated IgE mediated reaction, it's better to avoid cephalosporin. If patient is having penicillin associated IgE immediate type reactions, of course, if it is anaphylactic shock, history of anaphylactic shock with the penicillin, you don't give cephalosporin because there is some partial cross allergy between the penicillin and cephalosporins. If you have 100 patient with penicillin allergy, about 5 to 10% of them will be also allergic to cephalosporin, right? But again, it's very important to remember that if someone have type 2 or type 3 hypersensitivity reaction to penicillin, right, it's not a big deal, you can give cephalosporin if it is must. But if someone has history of type 1 hypersensitivity reaction with penicillin, it's better not to try cephalosporin and look for alternative drug. Am I clear? So that is why it's very important to know that the person who is having allergy to penicillin, what kind of allergy is there. And how do you determine that immediate type penicillin sensitivity is there or not? By skin injection. When you give test dose under the skin, patient develop within few minutes reaction to penicillin. It means that he is having type 1 hypersensitivity reaction. And then of course, it's better to avoid cephalosporin. Am I clear? Right? But if there are some other type of penicillin allergy and you need to give cephalosporins, you can. What could be such situation? For example, when someone is suffering with the Staphylococcal aureus infection, and that Staphylococcus aureus which is producing beta-lactamases. Beta-lactamases of Staphylococcus aureus can break down the beta-lactam ring of penicillin but cannot break down the beta-lactam ring of cephalosporin, right? So in those conditions where penicillin G is destroyed by Staphylococcus related beta-lactam ages, you can give first generation cephalosporin. Am I clear? Okay. Then we go to the another side effect related with the penicillin. Another type of side effect is that when penicillins can produce, especially that side effect is more common with ampicillin, right? That some penicillins, especially extended spectrum penicillins in heavy doses for prolonged use can produce diarrhea. They can produce diarrhea. Why extended spectrum penicillin can produce diarrhea? Especially ampicillin. Yes, my friend. Because let's suppose you are giving your patient orally. You have two patients. In one patient you are giving orally amoxicillin. In other patient you are giving orally ampicillin. Which has more chances to produce diarrhea? Ampicillin or amoxicillin? Ampicillin. The reason being, when you are giving ampicillin, ampicillin is poorly absorbed from GIT. So it stays in GIT for longer time, goes to the distal part of the GIT and disturb GIT normal flora. But amoxicillin very effectively absorbed from GIT to the blood. So it does not stay in longer duration and higher concentration, does not disrupt the GIT flora significantly. Are you understanding it? So what happened? Ampicillin, right, especially when it is given orally, right, it stays in GIT in high concentration, as from GIT it is poorly absorbed. If you want to give penicillin for some systemic infection, you should give it parenterally. So ampicillin will disrupt the GIT flora, kill many gram-negative bacteria in the GIT and give a chance for, yes, what? Resistant bacteria to overgrow. For example, Clostridium difficile. And when other bacteria overgrow, they may produce diarrhea. Are you understanding it? See, though you don't understand it. Look, in the GIT, there are many bacteria. You are so rich in bacteria in GIT that in 1 gram of your fecal matter, the number of bacteria may be more than the number of human beings on earth. You are rich, right, as far as bacteria are concerned. Now, there's so many bacteria there, but usually we are not sick by those bacteria because all these bacteria are competing for the food and most of them are not pathogenic, and some of the bacteria in the GIT may be pathogenic but under normal circumstances the non-pathogenic bacteria are in such a big number, they don't allow the pathogenic bacteria to proliferate enough and produce disease. Are you understanding this theory? Whenever we are using broad spectrum antibiotics, especially in high concentration and for long time, then many of the normal bacteria in GIT are killed. And if there are resistant bacteria which are pathogenic, they are not killed by broad spectrum antibiotic, they will overgrow because their competing normal flora is eliminated by broad spectrum antibiotic. When they will overgrow, the concentration will become high and they will be able to damage our GIT and produce diarrhea. Sometimes they damage the GIT so severely that they produce a condition called pseudomembranous colitis. What is the condition called? Pseudomembranous colitis. Ampicillin can produce this. Pseudomembranous colitis, what happens? That normal flora of GIT is killed and pathogenic bacteria overgrow, especially Clostridium difficile. That overgrows and that damages the GIT mucosa a lot and produces severe inflammation in GIT mucosa and produces bloody diarrhea. Is that right? Am I clear? So this is one more side effect of all broad spectrum antibiotics, including extended spectrum penicillins. Clear? Then another group of side effect, yes, what is it? Nephritis. In the kidney, some of the penicillin can produce nephritis, inflammation of the kidney. The most notorious regarding nephritis is methicillin. What is that? Methicillin. Methicillin and Penicillin can also produce nephritis, Penicillin, but less often. Methicillin is very, very notorious to produce severe nephritis. It was rather, I must say, so notorious that now in USA they have removed all the product. Methicillin is no more available. Methicillin is no more available for human use because it was producing very high incidence of inflammation in the kidney, damage to the kidney and nephritis, right? But some of the other penicillin like Penicillin less often can produce nephritis, right? Then neurotoxicity. Penicillin and their metabolites, if in high concentration reach to the central nervous system, they irritate the neurons. Penicillin and their product can irritate the neurons. You will be surprised that if this is a neuron and this is some cationic channel, suppose calcium channel or sodium channel, penicillin and their metabolites can disrupt their function. A lot of cations are loaded in the neurons. If a lot of sodium or calcium go into neurons, neurons get overstimulated. So they are irritatory, excitatory to the penicillins in very high concentration. If they reach to the central nervous system, they can irritate the neurons and even they can precipitate seizures, especially in the patient who have tendency of epilepsy. That is why we avoid giving penicillins intrathecally. Intrathecally means we don't give penicillin in subarachnoid stage, subarachnoid space. Secondly, if penicillins are given in those patients who have renal failure, you know, main route of most of the penicillins are eliminated from kidney, and if there is a renal functional impairment, then penicillin may accumulate in the blood and they may, if they can cross blood-brain barrier, they may accumulate in such a high toxic concentration in central nervous system, they may precipitate seizures. Is that right? Then some hematological toxicity, bone marrow house. One of the very important toxicity related here is platelet dysfunction. Platelet dysfunction. Some of the penicillins can bind with the platelets and alter the platelet surface receptors. And if platelet surface receptors are altered, the capability of platelet to aggregate is reduced. So some of the penicillin can disrupt the functional aspect of the platelet membrane and reduce what? Aggregation of platelets and produce bleeding tendency, right? Especially those penicillins which are with the James Bond. You remember which were the James Bond penicillins? Carbenicillin and ticarcillin. So you can remember car can hit the platelets as well as tick can bite the platelets, right? So ticarcillin and carbenicillins, which are well known anti-pseudomonal penicillins, right? They can damage the what? Platelets membrane and then there is tendency for bleeding. Moreover, penicillin can also produce neutropenia. One of the mechanisms may be when neutrophils are, surface proteins of the neutrophils are altered. Surface proteins of the neutrophils are altered, and if anti-penicillin antibodies react with the altered proteins of the neutrophils or granulocyte precursor cells, the cells in the bone marrow which produce neutrophils, if they are hit by the immune reaction, you will develop neutropenia. Are you understanding me? Right? Then we can come to cation toxicity, the last side effect, right? Last side effect is cation toxicity. Most of the time, penicillins are given as salt of sodium or potassium. Penicillins are given as salt of sodium or potassium. If penicillins are given injected as salt of sodium and penicillin therapy is in high concentration for many days, so much sodium is loaded, sodium is positively charged, so much cations are loaded that sodium may hold the water and dilute the potassium in the blood, and dilutional hypokalemia may occur, right? That in these cases, of course, you should use those penicillins which are highly potent, because penicillins which are highly potent, they need to be given in small doses. So cation toxicity will not develop. and especially penicillin when you are using in the patient with severe intractable congestive cardiac failure. You have to use the penicillin which are highly potent, because if you use less potent penicillin with a lot of cation load, that is not good for the patient's hemodynamic aspects. Am I clear? Do you have any question about the penicillin side effects? Yes, please.
What about use of ampicillin and complex, B complex? Because they change the natural flow of the GI tract.
Yeah,
To use?
look, no, it can be good, but again, you are talking about this, that whenever we use broad spectrum antibiotic, many microbes in the GIT are killed, and many of the microbes in the GIT are responsible to give us a good supply of B12. So usually whenever we give broad spectrum antibiotic, especially long time, it's very wise to give B12 complex with them, so that as GIT microbes are eliminated, right, then B12 deficiency should not develop. Is that right? But that can be a good combination. That is not an issue with that. Any more question? No question? Class dismissed.
So this was my last